Today will be our March 16th Pebb board meeting, and I'd like to welcome you all to today's meeting. Let's get started first with a roll call. And again, I'm Kimberly Hendricks, the chair. Kate Nass.
Good morning, I'm here.
Good morning. And Dana Harganani has been excused. Kim Harmon.
Here, good morning.
Good morning. Sean Parkman.
I'm here. Good morning.
Good morning. Mark Perlman. Not yet. Saban Martin.
I'm here. Good morning.
Good morning. Jeremy Vandehey. Senator Betsy Johnson. Representative Andrea Salinas. All right. Good morning. All right. As we can see on the agenda here, first order of business is our review and approval of the February 16th minutes. Is Ali on? I didn't even check to see if Cindy and Ali.
Yes. Good morning, Kimberly.
Good morning. I don't have the screen where everybody's on. I'm looking at the agenda, so good morning.
And we do have a quorum.
Oh,
barely.
thank you. Barely. Well, I'm sure Mark will join us.
Yeah, I'm sure Jeremy
probably
will.
Just started a little too straight up on the 9:30 button there.
Yeah.
All right. So did you all have a chance to review the minutes from the February 16th meeting, and do I have a motion?
I reviewed the minutes as a Siobhan, and I will make a motion that we adopt the minutes as written.
Thank you.
Second.
And we have a second by Sean Parkman. Thank you. Do we have any questions or comments? All right, since we're on screen, let's go ahead and do the dance. Kate Nass, do you approve the minutes as written, or the motion as written, sorry, or as said?
Yes, I do.
I'm going to have to get in gear here, you guys. Sorry.
You're good. No worries.
Kim Harmon, do you?
Yes, approve.
Thank you. And then Sean already said. Mark, have you joined us? Mark Perlman? Okay, and then Sean did Saban did the first. Jeremy, were you able to join us? Okay. Does anybody oppose the motion on approving the minutes as written? All right, looks like our minutes have been approved. All right, Ali, good morning. You're up. Director's report.
All right, thank you. Yeah, my mute button was stuck there. So before I get into legislative update, I just wanted to update the board on the progress of the consultant RFP and our newly established joint Pebb and OWEB Health Equity Work Group. So the consultant RFP is in process and scheduled for presentation at the April board meeting, so next meeting. Staff has been busy developing the structure of the RFP and the decision-making processes that will be discussed next month, such as the elements of a joint RFP. We're talking about ethics, conflict of interest, and other laws, leadership group for the planning and ongoing administration of the RFP, a selection committee for the evaluation and scoring of proposals, and of course the interviews. So we'll have a lot of information next month, a lot of decisions to be made, and look forward to the discussion. So regarding the formation of the joint Pebb and OWEB Health Equity Work Group, I'm happy to report that we have 2 board members from each board committed to this work group. They'll work closely with our PMAC and worksite wellness committees to develop recommendations to the boards among several different areas. We envision the first subcommittee meeting likely to occur in May, and currently are working on a draft charter and the first few meeting agendas and materials. So we look forward to sharing more details in future meetings. I wanted to give big thanks to Siobhan Martin and Sean Parkman for representing Pebb on the work group. And OEB will be represented by Susan Reike-Smith, who is the superintendent of Tiger Tualatin School District, and Dr. Tom Siltabo, who's he's the retired medical director from Kaiser. So it should be a really good group, and again, they'll be working closely with PMAC and our Worksite Wellness Committee, and a lot of exciting things that we have planned for that work group. So more to come. All right, brief legislative update. Things are really starting to pick up quite a bit. I'm sure many of you are kind of in the same boat. We're coming up on a few key dates. April 13th, last day to hold a public hearing and work session and referred policy committees in the first chamber, other than, of course, Ways and Means and Finance and Revenue. Work sessions must be scheduled by March 19th, so that's coming up in a few days. May 28th is the last day to hold a public hearing and work session in the referred policy committee in the second chamber, unless it's those Finance and Revenue and Ways and Means. And then constitutional signing day anyway is June 27th, so we'll see if we can make that date. Probably the bill that we've been most involved in is House Bill 2810, which requires Pebb and OEB to offer at least one integrated health benefit plan meeting specific requirements in 2023 and applies to all health benefit plans offered by Pebb and OEB by 2026. So an integrated health plan, if you envision Kaiser plans, that's kind of what the bill describes among many other provisions. It's not received a hearing yet, but it's sponsored by Representative Dexter, and she's done a lot of work to pull all the Pebb and OEB stakeholders together, including staff, to discuss how they can move integrated healthcare further along. So we've been meeting bi-weekly and trying to provide the information that she needs and the input that she desires. So we'll keep you all updated on this bill. The next one is Senate Bill 12, which I believe is scheduled for a public hearing this week. This one would require benefit plans offered by Pebb and OEB to cover certain costs related to travel to Mexico or Canada to fill and refill prescriptions. A small subset of drugs that are covered by Pebb and OEB, and obviously very expensive ones. This bill, we've done a lot of analysis on this bill. It could potentially result in minimal savings. I say minimal. $500,000 is a lot of money, obviously, but fairly small amount when you look at the overall pharmaceutical spend. There are a number of regulatory issues that we would need to clear to essentially sponsor our members on trips across borders. So we will see if that one has staying power, especially with COVID right now. We obviously can't even get into Canada, so a lot of hurdles to overcome for that one. The next one is House Bill 3044, which prohibits Pebb and OEB and Oregon Health Authority from contracting with carriers or CCOs that do not sign the Senate Bill 889 compact, which is what Jeremy spoke about last month and the board took action on to support. So this one's kind of moot as long as our carriers comply with that, which I believe they were on the list, is doing. We can move on from that one. Senate Bill 845, would add one member of the public who has experience in administering employee benefits to the Pebb board. So this would make 9 voting members on the Pebb board. So that one, again, is Senate Bill 845. And those are kind of the key ones right now. They're still popping up. So we will keep the board and, of course, board leadership updated as that occurs. Any questions, comments, concerns? Thank you so much.
Thank you. Okay, so it looks like next up we are going to be looking at our medical dental vision renewals round 2, and Nick Albert and Mitch Negro, I'm going to mess that up, are going to present to us.
All right. Good morning, everyone. So Rose, do you want me to share my screen?
Yeah, sure. Go ahead, Nick.
Okay. All right. Just want to confirm everyone can see that.
Yes.
Okay. All right. Good morning again. So, yeah, this is Nick Albert. We also have Michael Garrett and Mitchell Nigro on the call with me to go over the renewals round 2 responses, but the predominant or the bulk of the conversation is going to be spent on the fertility benefit discussion. So we have a few follow-ups from round 1 that we talked about last time. We have an update to the composite rate with an additional month of data, and then we've requested a lot of information and a lot of benchmarking in relation to the fertility benefit. So we'll be presenting on all of that this morning. And Ali gave us plenty of time. I was just noticing on the agenda we have ample time. So we're expecting good dialogue with all the board members and anyone who wants to join in the conversation. I know this particular topic, fertility, we did receive 3 written public comments. So hopefully the board members had a chance to look at those as well. But we can also speak to those if needed. I think there were some great background and feedback from Pebb members. So as I talked about, we have some updates for you all for the round 2 renewals. The bulk of the conversation is the fertility and inclusive family planning discussion. We do have an update on the transgender benefits and the WPATH alignment. So I think Siobhan, actually, I think you brought this up at the last board meeting. So we do have an update for you. So we finally received all of the sort of costs and confirmation related to that. So we'll talk about that and what alignment would look like to WPATH. And then ultimately we'll get to the next steps. So this slide deck is 42 slides, but actually half of those are appendix. So we have plenty of time to talk about the bulk of everything that's going on. So guiding principles. We structured the fertility benefit in particular when we're thinking about what we are recommending for the fertility coverage. We structured our recommendations around not only these guiding principles, but on the next page, the health equity guiding principles as well, and the health equity strategic pillars, particularly the populations that are areas of focus for Pebb that the Pebb board decided upon would be areas of focus. Really, when you think about fertility benefits, and I know I'm sort of jumping ahead, you think about struggles that some people have had and the associated costs of these treatments. And so we structured our benefits to provide help to those who need them, or our recommendations to provide help to those who need them, but also be good stewards of Pebb's money, because obviously we are working within a 3.4% cap. So there are two sort of dueling principles and goals that we have here. For the health equity strategic pillars, the one piece that I would want to call out is the priority population list. So when we looked at the priority populations, the one that we focused on for this particular piece was the people with low incomes. We wanted to provide a benefit on the fertility front that would allow all Pebb members, regardless of income or economic situation, to be able to access these benefits. And so you'll see some of our recommendations involve no cost sharing, a relatively rich benefit compared to what we see in the market. But again, we think it makes sense just given your strategic pillars on that we discussed here over the past few months. Any questions or commentary before we? Oh, I'm sorry. One more. So within each renewal meeting going forward, I think it would be helpful, and this is more, not only for Mercer's benefit, but probably for the board's benefit as well. We're going to include a slide with recaps of prior board decisions. I think that helps, keep us on track with kind of reminding, okay, this is where we've been, this is where we still need to make decisions. So the only decision that we had in last month's board meeting was the extension of the COVID-related treatment to the end of the month following the end of the national public health emergency. We accepted that proposal for both Providence and MODA. This is now in alignment across all three of your medical carriers. So this is what Kaiser was already practicing. So this actually now allows us to not have to re-vote on this issue every month or every few months here. So all of your carriers are now covering both treatment and testing costs at 100% on behalf of your members. Okay, so the composite rate. So this slide has changed slightly compared to the last board meeting. So what we did with the self-funded projection, so all of your self-insured carriers, so statewide choice, MODA Medical, MODA Dental, and VSP, so all 5 of those, we updated with an additional month of data. So we have incurred claims still through 2020, but we added run-out data basically through January of this past year. You can see that the 2022 composite increase is projected to be at 2.6%. This is an increase from where we presented last month in February. Last month, we presented a 2.3% increase. So it updated slightly, it changed slightly. One of the things that Ali is going to be discussing after this presentation is an update to the Pebb admin charge and the Pebb consultant charge, or I guess the commission charge that we bake into these rates. So that is updated and that's reflected in these. So it's not only an additional month of data on the self-funded plans, but it's also those two fee increases essentially that we're accounting for within the 2.6% here. What this means is we essentially have $8.1 million to play with for 2022. We have a buffer of about 8.1 million in relation to the 3.4% cap that we're subject to. Any questions? Okay.
Hey, Nick, this is Kate Nass. Hi.
Hey, Kate.
I have a quick question, and I personally am combing through the most recent American Rescue Plan. Is there anything in there that provides payments to providers or plans to help cover the cost of COVID-19 treatment and whatnot? I know we're covering it, which I'm happy to, but I'm curious. I want to account for the fact that there might be additional revenues or resources for the system.
Yeah, that's a great question. I have not personally seen anything related to that, Kate, but let us follow up. A lot of the regulations are obviously what you hear in the news about the direct payments, but there's also some COBRA. There's some COBRA continuation guidelines that have been expanded. So those are kind of the big benefit items that I've heard of. We'll check if there's any direct payments to providers included.
That'd be great. I just want to make sure
Yeah.
I'm not missing something. I personally am also combing through it and haven't gotten to that level as well. So
Yeah.
thought I'd just ask you too. Thank you.
Yeah, and just as a note here, so we're looking obviously at 2022 projections right now. So if there are any payments to providers or anything that's offsetting the cost of coverage here in the 2021 plan year, we don't expect anything to continue like that. So we're assuming COVID essentially for modeling purposes. We're no longer providing, free treatment, free cost sharing into the 2022 plan year. Of course, let's all knock on wood and hope that truly is the case. But yeah, exactly right. So from that perspective, it wouldn't change anything on this slide that we're projecting out. But point taken. We'll take a look at that and follow up, Kate.
And
Thanks,
Nick, this is a bit of a follow-up. Just these numbers that we're looking at here are the historical adjusted numbers. And I know that when we're projecting the numbers when we vote in May or June of each year, they're often higher.
Mm-hmm.
And then they get adjusted over time based on claims. And I do think that that is something we should be thinking about as we move into the following plan year, the 2022 plan year, because we make decisions like, and I know we're going to have this discussion about fertility, and we have put off expanding benefits to people who now aren't going to be able to take advantage of those benefits because we put it off because we thought the increases were going to be higher. And I know we're going to dig into the admin fee increases. And what I find challenging is that, we're going into another year where the claims are down because people are still not back to seeking the health care that they may be putting off. And then we're going to be looking at adding some benefits. And I understand that adding benefits, we have to plan for those cost increases about adding benefits. But, our admin fees go up, our other costs go up. And but we're projecting and claims have been down. And it feels, I guess I don't entirely understand, and I know we'll dig into this more, but why we see some of the increases around admin fees, which then have us make different decisions around benefits that we're offering because we have to continually balance with the 3.4%. And I'm just noticing that historically, we, for most of these years, we have been well under the 3.4%, except when we had to add a premium tax assessment, and then in 2017, but at the end, the adjusted rate was quite close.
That's exactly right. And so when essentially what we look at is this column at time of renewal. So we use the current year's March census and whoever's enrolled in the plans as of March. So right now we still have the January census. So that's why in April we'll ultimately come to you with a more complete picture of what the composite rate looks like as of using the March census. But to your point, Siobhan, we always see switching. So people over the course of the year, over the course of, the last, 5 years or so, have switched from higher cost Pebb plans to lower cost Pebb plans, from family coverage to child coverage. There are some switching going on that we take into account in these numbers that are really not, we're not able to at time of renewal. So to your point, there is usually some room, but I believe how it functions as far as 1067 goes is we actually need to ensure this number at time of renewal is under 3.4%. We can't necessarily rely on the fact that switching may get us under the 3.4%. So I think that's at least the function of it. But to your point, Siobhan, we have some admin fee follow-ups coming shortly here. And this is by the way, and let me switch to the next slide because this goes through the increase by each respective carrier. So we have some follow-up coming on specifically on the admin fees for Providence and MODA. I think it's important for perspective to keep these admin fees, I guess, in relation to the overall claims cost. These admin fees make up about 3.5% to 5.5% of the total premium Pebb is paying. So the bulk of the premium and the bulk of the, composite essentially are your underlying claims costs. And so having the admin fee discussions is very important, and it's important for the carriers to justify why they're proposing increases to the admin fees. I think for the board's perspective, Mercer's perspective, it's also important to realize that the majority of the costs are really from the underlying claims themselves, not necessarily the admin fees associated with the administering the plan, so to speak. Even though that's not to absolve any carrier or anything like that. It's just because every little penny does add up when we're talking about, fertility benefits, when we're talking about alignment with WPATH. Every dollar does add up, but just have that perspective in mind. So what I just want to call out a few changes. So again, we updated the self-insured projections with one additional month of data. So we have additional month of runout. So essentially that means is we have a more complete picture of how 2020 actually ended up because we continue to count additional months of runout for the incurred claims. The Providence estimates changed slightly. So statewide increased from a 0.9 to a 1.1, but Providence Choice actually decreased from a 4.3 to a 4%. So together, those two, actually, it's pretty much net even. So if you add the total premium dollars, it's only about a $200,000 difference or so compared to where we looked at last month. For MODA Medical, that increased slightly. We had a slightly larger decrease projected for MODA Medical. So that increased a little bit, and then for VSP was the other one that actually went from I think a negative 0.6% to a negative 1.4%. But VSP, doesn't make up a large share of the overall composite. That's for sure. So there was some movement, but overall, they're really we stay relatively unchanged from our prior projections. And then I'll just Kaiser Medical and Dental, for that, actually not dental this year, but for medical, they are going to be releasing their final renewal at the April meeting. In time for the April meeting. So we'll have Kaiser's final update. So Kaiser has remained unchanged since their preliminary update or preliminary offer. So we expect that to have some movement coming up in the next month. And none of these include, by the way, any of the changes that we're talking about. So this is strictly on a status quo if Pebb made no changes at all to the benefit plans for 2022. And so this gives us a nice baseline to work with and see where we're at if we made no changes.
And Nick, I definitely understand your point around it's the underlying claims costs that drive increases. It's just my understanding is that claims have been way down, and we have those slides later in the deck because of COVID. And just wanting to better understand, and my recollection is we have a couple more slides on the admin fees, but just understanding the changes and why some are going up and some are going down. And we do end up in a position where we're looking at every penny so that we can think about things like expanding benefits. So thanks.
Yeah, absolutely. And so I should note, we tend not to get into the details of underwriting within the board meeting. I think that may tend to put the general public asleep. But what we do is when we take 2020 claims data, I think I said this last meeting, but we have to adjust it up, right? We don't think 2020 is a good indication of where actual claims will end up being for future years. And so when we're making projections into 2022, 2023, we're using 2020 claims, but we're actually grossing them up by anywhere from 3 to 6% or so. So MODA is actually a really good example of this. So you see the decrease on MODA of 3.3%. That is even inclusive of the adjustments we've made to their underlying data. So MODA's budget rates for or premium equivalent rates, we feel are a little bit too high right now. So even with that adjustment for 2020 claims being lower than where we would expect, MODA is still coming in with a decrease because their claims have just been even lower than the drop in COVID claims. So that's a good example of a plan that is functioning really well in comparison to where the budget has ultimately kind of landed over the past few years. Okay, so we had a few follow-ups from round one, and before we get into the admin fee discussion, I know we went through some slides last time showing the 2020 claims and the loss ratio for each of the various self-insured plans. I think Siobhan, you mentioned that it would have been helpful to see 2019 data overlaid on top. So we've included that in the appendix. You probably saw, but I just want to call to the rest of the board members' attention that if you were looking for the 2020 claims experience for all of the self-funded plans, it's in the appendix now. And we do have the 2019 loss ratios kind of overlaid on top of those charts. So it should be a good comparison point between the years. So slide 9 goes over the self-insured administrative fees for the medical carriers. So we have statewide choice, MODA. So MODA, as you recall, has two components. They have the base administrative fee, and then they have the MODA 360 fixed cost component. We shrunk down the tables. So in the last board meeting, we had all the various components of the admin fees broken out. This table or these tables just go into the grand total sum of what's happening with the admin fees. So statewide and choice again are increasing at 3.5 and 3.4% for 2022. MODA is increasing at 2.9, and then the fixed costs for MODA 360 are increasing at 3%. We requested the carriers to provide further information and justification for the proposed fee increases for 2022, especially in the context of their fees are higher than what Mercer sees as benchmark across most of our clients, all of our clients. So we wanted some additional justification and rationale for why their fees were increasing or are expected to increase for the upcoming plan year. What you see on this slide is essentially their responses. This is not Mercer's, kind of finagling their responses. We wanted to provide their responses directly to the board. So for Providence, their admin fees, as you would suspect, cover additional or operational costs with administering the Pebb plans. They do want to point out that a portion of the admin fees are associated with that triple aim incentive. With more to come on that. So I will say, for those of you who are tuned into the innovation work group discussions, there are ongoing discussions about performance guarantees across all of Pebb and OEB's medical carriers. So those are likely going to be subject to change as far as the triple aim incentives for Providence. I think the innovation work group, they're going to be talking more this afternoon, but likely the recommendation will be for the board to not proceed with those triple aim incentives for the upcoming plan year for Providence. But more to come on that front. I don't want to speak for Margaret or I know Michael is obviously a part of that work group, but just keep that on the radar for the next board meeting. Providence does want to call out the fact that the admin fees are the lowest of all the self-funded plans, which is true. But again, the fees are still high compared to where we see as benchmark. And then they include all the administrative functions and health improvement programs. So, HEM is included in there, their work on the HEM program. And then they do include for Providence the pharmacy benefit manager fees and services. So they did want to call that piece out.
Hey, Nick. Oh, go ahead, Sean.
You first.
I just had a question because, these are the aggregate increases, and last time you went into more detail. And did Providence address, that the network access fee they had highlighted as a key driver of cost, but then you said that they were going to come back on that because that's supposed to save overall for the plan. So
yes, yeah. So they did not come back on that. That was Mercer's call out on some of the things that were changing. So that was our sort of, just wanted to call that out to the board. A piece of that, Siobhan, is the transition that Providence is making from First Choice First Health with their WRAP network to Cigna/Clear Health. Providence provided an analysis to Mercer that we are currently reviewing. That their analysis did project savings to Pebb, with the switch to Cigna for their wrap network and Clear Health for their out-of-network claims repricing. So there are two components that they are changing effective June 1st of this year, that they did project savings for Pebb across both choice and statewide. We are validating and verifying that internally. So I don't want to speak to that, but yes, that will likely drive additional savings in the plan over and above the increase in fee for the network access.
So we should see that show up when we get the increases in April, like the final.
That's exactly right. Yep, that's
Okay.
exactly right. The Providence piece, so the 1.1 and the 4% for statewide and choice, respectively, will be lower by some magnitude as a result of their enhanced out-of-network or out-of-area agreement with Cigna.
So, Nick, I don't know if I'm really understanding the first bullet point. Under Providence, a portion of administrative fees are associated with the AAA incentive. Is the way that I'm understanding it, so I'm looking for you to redirect me here. Am I understanding the way I'm interpreting that is basically because we're asking for performance guarantees and fees at risk, therefore they're charging us more in order to hedge their bets?
No, but Providence is quick to point that out only because there's no such no equivalent fees at risk as far as triple aim or PPM on the MODA side. So Providence proposed the triple aim incentives. Originally, there were $15 per employee per month for both statewide and choice as part of the 2015 medical RFP. They came to the table and said we'd be willing to put these fees at risk. If we meet these metrics, we get to keep our money. If we don't meet those metrics, we'll pay you back. Pebb is still paying the full cost of the $59, $78, whatever it is, right? But at the end of the plan year, when Providence does their annual accounting, typically in the March, April, May timeframe, right? They have to wait for runout claims to process. They will, depending on whether they meet those metrics, they will refund Pebb. If they meet all the metrics, then all is good. Pebb will continue to pay the full fee without any refund owed back to them. We received indication from Providence, Sean, that even if Pebb did not elect the triple aim incentives for this upcoming plan year, their base administration fee would increase commensurate with those triple aim incentives. So essentially, you remove the $13 from the triple aim, they would put it back into the base administration fee. So the total fee would remain unchanged. And that is the guidance we received from Providence as of last week. So the $59.27 for statewide would remain unchanged, even if the board did not elect the triple aim incentives for the upcoming plan year. So I don't know if that answers your question or just makes things more unclear.
Maybe we'll try it again later.
Okay. Like I said, part of the work, and actually, Sean, you're obviously well aware of this, in the innovation work group, is a reconfiguring of the performance guarantees across Providence, MODA, and Kaiser, making them uniform across the carriers, making each carrier have a certain percentage of their fees at risk instead of tying it to fixed dollar amounts, for instance. Like the Providence triple aim incentive is just a fixed dollar. And I think in the January meeting, we showed that the triple aim has remained flat, but the admin fee keeps increasing. So as a percentage of the overall admin fee, the triple aim is actually comprising less and less of their fees at risk, or less and less of a percentage of the overall fee as we go on down the years. One of the goals within the innovation work group is to make all the fees at risk just a percentage of the admin fees and remove the triple aim incentive entirely from the Providence piece.
Yeah.
Yeah.
So we don't have to dwell on this, we have business to do, but I'm trying to I'm hearing the words you're saying, and I'm trying to figure out where what I said is not true. Because what I'm hearing you say is that they're raising their fee, so that the proportion of fees at risk is lower, which is hedging their bets. That's what that word means. So I'm trying to understand how.
Yeah, I would just counter that they aren't hedging their bets, because if they were, and we requested them to remove the AAA incentives for the upcoming year, you would think that the total fee paid by Pebb would actually decrease. But in reality, they are shifting some of their base administration fee into those AAA incentives. So when we get rid of the AAA incentives, or we propose to get rid of them for 2022, the actual base admin fee, which is not broken out in this table, would actually just increase again. So
Okay.
even though they are quick to point out that they have fees at risk, it's really just a shifting of their base admin fee into the AAA incentive. So they're not hedging their bets. It's just they're shifting dollars around.
Okay, I'm with you on that point, but how does that, again, I don't know if it's useful for us to dig in right now. Like, this may be an offline conversation, but then how does that relate to their overall fee increases, I guess? You know what I mean?
Well, in the context of this question that we posed to them,
right,
it doesn't.
Okay, so that's why I'm trying to figure out, why is it here?
No,
what point are they trying to make is what I'm trying to get at.
No, that's a valid point, Sean. Quite frankly, Providence and MODA did not provide, in Mercer's opinion, justification for why their fees are increasing for this upcoming year.
We can put that to bed. Thank you.
Yep.
That's what I was.
Sorry, I didn't know you were focused on the increase versus just the overall base. All right, we're on the same page. I got it. And so moving on to MODA, MODA essentially, as part of their enhanced program, continuing to expand on their capabilities and tools and systems, they require periodic inflation-based increases as necessary, and periodic generally means yearly in this case. So MODA's response essentially was around inflation, so 2.9% for inflation, and continued investment in their systems. So, sorry, I'm going to cut someone off. Okay. So that was the responses we received. This is not the end of this conversation. So I wanted the board to know that Mercer is continuing to have conversations with both Providence and MODA on their administrative fees. Both seem willing to at least come to the table and talk with us. So this is not the end of the conversation. And within the round 3 responses that we'll be releasing this Friday, or rather requests, we will be updating or requesting their best and final admin fees for this upcoming plan year. So more to come on this.
Yeah, so kind of a next segue into admin fees. So in the round 1 renewal responses, MODA proposed MODA 360 with dental integration, which is essentially just expanding their 360 to those on the dental plan. And this came with a 46 PEPM charge, so per employee per month. So in round 2 renewals, Mercer requested that MODA just waive this fee since it's a little bit smaller. MODA's response is kind of over there in the dark blue. So essentially their response was, with the additional costs of having health navigators, they would essentially need this fee because of their associated costs, as well as enhanced digital tools. So we were hoping that MODA would waive it. Unfortunately, it doesn't look like they are willing to. And then another follow-up was on the vision therapy. So again, vision therapy or eye taming for, again, those items over there on the left. So I believe there was a question on, how many plans does VSP actually have with this? So typically your vision plans are going to be for, hardware, contacts, eye exams. So over there, that second bullet, you can kind of see of the 62,000 groups VSP has, only 157 currently offer this plan or offer this rider. And sometimes you'll see it under medical plan coverage, but we've checked the MODA, Kaiser, and Providence plans, and currently these are not covered.
So I think Kate may have had a question at the last board meeting because I think there was just general consensus maybe that these would be covered under the medical benefits, but as Mitch alluded to, it's only covered if very rarely when physical therapy is involved for some of these conditions. So if it's part of the physical therapy portion, then it would be covered, but likely it's excluded from the plan, and so that's where VSP would come in and cover the costs of these services.
Thanks, Nick. I appreciate you following up on that. I think there was me and another, I can't remember if it was Sean or Siobhan, but there was a couple of us that were questioning, so thank you.
I didn't mean to call you out specifically, I guess. But yes, it was I think Mitch and I, as we were doing research, it's a little surprising. Again, this has not come up on any of our other clients, and as you can see by VSP's benchmarking, it is relatively rare to offer. So I think this would be a really nice enhancement, again, as we're thinking about benefits for the upcoming plan year. Okay.
And I know, Mitch, and sorry to take us back to the dental slide, but just to go back to your point, what MODA got back to us and said, we're essentially like, we need to raise the per employee per month for everybody by 46 cents because we're doing this dental integration. And I know Sean made the point last time that, we pay fees for the integration, which we would expect would bring down costs overall. And I know that was a big discussion we had a couple of years ago on the Pebb board when Kaiser did the dental integration, and knowing that good dental health care is also good for the overall health care for somebody. And so would we expect to see costs go down because of better integration? And is that going to be baked into the final numbers for MODA as well? Just curious about that.
With regards to potential savings, MODA did not provide any estimated claims impact for this change. And in our opinion, I think this would fall more in the enhanced member benefit spectrum as far as just ease of coordinating with MODA, ease of coordinating care. I wouldn't necessarily put a hard claims dollar savings on it, even though, to your point, Siobhan, there are certainly benefits of being able to have integrated systems and functionalities working between medical and dental. I think it'd be too hard to forecast savings.
Okay, thanks.
Nick, to that point, I'm looking for like a brief comment, and this might be just like a topic for the future, but sometimes I've been curious when there's these integrations, not just about MODA, but just in general, where there's like enhanced integration, things like this. It's not like when a organization does that, they're only doing it just for Pebb, like they're integrating presumably the whole thing, like for every client. And so the question is like, are we paying for that for everyone? Like, I'm happy to like, I don't know if I'm happy, but there's something to be said about like contributing, I guess. But I'd be curious, like, do other clients are they kind of spreading it across a bunch of other clients, or is Pebb like in a role of like funding an organization's upgrades that they're going to use for other, because that's not just like I don't feel like I'm being like unreasonable to ask, because I've actually had a medical system tell me that that's what they do with Pebb. That we fund their, they need us in order to do something for Medicaid, for example. I've just had someone directly tell me that once. And so that's why I'm asking, like, are we funding? Yeah, what do you think about that?
So for Moda 360 in general, I want to say their only clients that rolled this offering out were OEB and Pebb for this past plan year. So from that perspective, this is really a new approach that they're working on behalf of Pebb and OEB. From that perspective, Sean, I want to say the dental integration is likely going to be taking place for a lot of their customers, including probably their fully insured line of business as well. I don't know if it'd be helpful to have Erica jump on and just add a commentary or two if she's on.
Yeah, hi Nick, and thanks for that. I sent a little comment through. Sean, so the dental medical integration would be only for Moda 360. So right now, as Nick had said, the only groups who we have rolled out Moda 360 to are Pebb and OEB. So the admin fees that you pay for Moda 360 are only used to support you. And so we would not be integrating for the rest of our book of business or for our fully insured business. And, just to provide a little bit more detail on what that looks like, it is an enhanced member experience and member support. So when our members are calling in to or reaching out to our health navigators, bringing in dental, what that does is it allows the health navigator to really be able to close gaps in care and make connections for both medical and dental. And then there's also the support on the clinical side where we are integrating the data, and then it's used for predictive outreach for members. So for example, members who we have identified as having periodontal disease, we know that they are at higher risk for readmissions after certain surgeries. So that would be used to predict and outreach to those members for engagements in our clinical programs that we have. On the health navigator side, we would be able to see members who are diabetic and if they are connected with a dentist, and if that dentist is also a dentist who participates in the Health Through Oral Wellness program. So for example, when they're working with our health navigators, we can help connect them, if they're diabetic, to the services that are available and appropriate for them. That may mean making sure that they have had a dental visit within the last year and connecting them to a dental provider that participates in that Health Through Oral Wellness program to help close those gaps in care. And we would also, if the Pebb board would like it, we can absolutely have Dr. Barrichello come and do a quick presentation on what that would look like, if that would be helpful at all.
Thank you, Erica.
Yeah, thank you.
Sean, does that help provide some clarity?
Yeah, that's helpful.
Okay.
I think it, in general, it's just a good question. I think with a lot, on the one hand, Pebb and OEB have a role to play to help improve efficiency and lead in healthcare improvement in the state, as does Medicaid. On the other hand, we want to be sure that if system improvements are needed across multiple programs are pitching in. You know what I mean? So, so that's less of a comment about this particular detail, as it just kind of brought it up because this isn't the first nor the last system improvement. And then kind of to our previous point, which we do not need to redwell on at this moment, but just kind of like the ongoing saga of, Representative Greenlick's guiding lights. Like, are you paying for something that should be happening anyway, as if it's an increase? It's just sort of like that, the eternal question. So it's just kind of like worth poking at that question, I think, as stewards of the public dollar.
Yeah, absolutely. Yep. Okay. All right. So turning our attention to the sort of the topic of the hour, the fertility benefits. If everyone is ready to move on, we certainly can. And by the way, that did conclude the bulk of the follow-ups that we had from the round 2 responses that we received. So again, there are still a few things outstanding. The Cigna piece with Providence is probably the biggest one outstanding right now that we would still need to incorporate estimates into our composite rate for that. But otherwise, we could talk about some of the fertility and enhancements that we're proposing. So for those of you who looked back at last March board meeting, you'll notice some similar slides that we presented, because quite frankly, not a lot of benchmarking has changed. Not a lot of what our recommendations have changed in comparison. We put this on pause last year due to COVID. And the American Society of Reproductive Medicine's recommendation that all of these fertility treatments be postponed if possible. And so we did that on the basis of that recommendation. And so now we're bringing it back into the fold here. So we wanted to first look at current state of Pebb and OEB's fertility benefits or infertility benefits, looking at some benchmarking, looking at what Mercer's guiding principles are regarding fertility benefits, and then ultimately what our recommendation would be. And there are still quite a few discussion points and items the board will ultimately have to decide upon. This is, as Michael can attest, this is an area that is very deep and very complicated as far as the amount of treatments each unique member can go through over the course of receiving infertility and fertility treatment. So our recommendations stem from not only Mercer, actuaries such as myself. We don't want the actuaries making all the decisions. We want the clinical expertise and the guidance from our clinicians within Mercer, alongside some of the external organizations that we cite within this section. So essentially what we have on slide 13 are the current coverage for Pebb and OEB. In the dark blue in the middle of the page is really what we're focusing on today, which are the advanced or assisted reproductive tech services, so the ARTs or the techniques involved. So IVF, ZIFT, GIFT, PGD, ICSI, and ovum microsurgery. And for reference, Michael added a glossary of terms in the appendix. So as we go through this, obviously the presentation itself on screen will be focused on the current slide, but to the extent that you have follow-up or questions afterwards, there is a glossary of terms included in the appendix as well.
Slide 39, Nick.
Slide 39.
Yeah, so particularly the items there in the dark blue, there's definitions. I would just say, by the way, it's Michael Garrett from Mercer, that these are just different kinds of the assisted or advanced reproductive treatments. So we just thought we would list them there specifically. These are, it gets very detailed about what they are, but if you want to know the definitions, they're back on slide 39. Thanks.
So essentially what Pebb has right now are basic coverage of infertility and the basic treatment and diagnosis. One thing that Pebb does cover that's not, I guess, not as common, but is a great benefit that you already do cover is the artificial insemination, including IUI, so the intrauterine insemination. So that is covered with a lifetime maximum of 6 cycles for artificial insemination, inclusive of the sperm wash as well. So the sperm wash essentially makes the sperm cleaner, for lack of a better term, and more receptive. So when you do the artificial insemination, it's less likely to be rejected. So that is a great benefit that's already covered, and the cost of those generally range between $1,000 to $3,000 per cycle for IUI. So that cost or that benefit is already covered, although it is covered at a 50% member coinsurance. So just keep that in mind as well if we do want to address that piece in any way. But the bulk of the conversation, obviously, as Michael said, is with the assisted reproductive technologies. So these are the services that, if basic treatment and drugs don't correct the underlying causes of infertility, these are the advanced ways that have shown to be effective for fertility treatment. Wanted to include a few slides on the benchmarking that we see. So this is a survey from the National Business Group on Health regarding fertility benefits. So on the left-hand side, you see the percent of infertility treatments covered by health plans. 84% cover the specialist, 81% cover the medication for infertility, and then 69%, if I jump down a few rows, cover artificial insemination. So those three benefits Pebb does cover. So the in vitro, the IVF, is covered by 71% of companies within this National Business Group on Health survey. So Pebb does not currently cover that. Egg freezing and egg and embryo freezing is out of the scope of this upcoming discussion. It is on our roadmap, though. So as we look for possible other inclusive family planning and benefits, that could be an addition. The middle column lists out the typical dollar limits and the types of dollar limits in place. So in the purple, 62% of companies do not have a dollar limit associated with their fertility treatments. 31% and 7% respectively have some sort of dollar limit, either a combined dollar limit for medical and pharmacy, or a separate medical limit and a separate pharmacy limit. But I found it interesting that a lot of companies don't have a dollar limit in place, so 62%. And then ultimately on the right-hand side, for those who do have some sort of dollar limit in place, what is the lifetime dollar limit for these services? The median is $20,000. The average is $23,800. To give you perspective, a typical cycle of IVF runs anywhere from $20,000 to $30,000. And a person undergoing IVF treatment may have to go through 3 to 4 cycles, possibly, to ultimately get pregnant. They become clinically less effective the more and more you go out, but it's not uncommon for a person to have to go through two or three IVF cycles.
And Nick, just so that I'm tracking, that's Pebb currently offers that, but at 50%. Is that right?
No, IVF is not. Yeah, IVF is not covered at all. So 50% coverage for, artificial insemination is the biggest example or the best example of that. So that would be covered at 50%. Basic treatment through the pharmacy plan, if there are drugs that can treat the underlying cause of the infertility, that's covered at 50%. So essentially, it's everything's covered at 50% besides these kind of assisted reproductive techniques, which are not covered at all right now.
Okay, thanks.
So Siobhan, if I could, Nick, and obviously this gets, we're talking about very delicate things here. In vitro fertilization is when egg or sperm are collected and then combined in a lab setting, versus artificial insemination where sperm is collected, then inserted into the person with the uterus and fallopian tubes. So that's the difference between the two. So it's the in vitro fertilization where it's combined in a lab that is not currently covered under a Pebb plan. So don't mean to get too technical here, but I
appreciate it.
Yeah.
Thank you.
No, that's okay. And I know I want to be sensitive to people's, discussing this may be uncomfortable, but just to be really explicit. So, and I think, Nick, are you going to talk about the health equity issue? Is that the next slide? Because I want to make sure.
It is one of them coming up.
Okay,
Yes, I'm
I'll
sure.
hold my piece then. Sure.
Yes. Yeah. So this is just a reminder, and this is again from our discussion last year, right? Even if we touch and we add benefits for the ARTs and the IVF coverage, that really covers, fertility and infertility support. There's a little bit of, coverage through all these that we'd still be missing, but there's a whole host of other benefits that are possible. And a lot of companies and a lot of organizations are providing coverage for. Surrogacy and adoption are the two that we have really no benefit for at this time. There are additional fertility supports, such as egg freezing, sperm storage, egg and sperm procurement. So we find a lot of these benefits are more prevalent in the sort of tech space, but quite frankly, they're becoming more and more common within other organizations too, because I think a lot of organizations are realizing that women are not, or I guess postponing pregnancy and traditional, family planning activities until later in life. And so that's when these benefits really provide a lot of value. So when when Pebb agencies and Pebb in general is competing for talent, these do make a difference, competing for talent across other organizations too. So we just wanted to make sure that we're talking about fertility today, but there are other things on the roadmap that we do have considerations for. So the guiding principles for the fertility benefits. So this is our recommendation, and so we basically took the items on this slide, and we wanted to design a fertility benefit that would align or try to align with as many of these as possible. The benefits should focus on the goal of facilitating healthy babies for all employees wanting a child, reflect the best science and practice. So as part of that piece, the science and practice part, we've asked your carriers on a number of items that we have in a few slides. So we have questions related to COEs. We have questions related to ESET, which is one of the guiding principles as well. So that's with the elective single embryo transfer, which is proven to reduce the complications associated and the multiple births associated with IVF treatment. Going back up to the removing unnecessary barriers of care. So this is the cost aspect, right? For a lot of people, I think for the majority of us on this call, $20,000 to $30,000 out of pocket is no joke. And so with the cost of IVF treatment being so high, we wanted to provide a benefit that allows all employees, regardless of economic status or income level, to be able to access these benefits. The second, or the fourth bullet, is the wise stewards of plan money, realizing that resources are not unlimited, and we are capped at a 3.4% cost threshold every year. We have some room this year, but that doesn't mean we can or should maybe provide, unlimited benefits, right? So there has to be some balancing of the benefits to our members, but also the stewards of the state's money, our plan's money. And then alignment with OHA Pebb goals on health equity. So that is new. So the rest of these were included in our recommendations in last year's, but obviously as the year progressed, we had an increased focus on health equity within OHA and within Pebb itself. So we added that, and partially one of the prioritized populations, of course, is low income workers. And so that's one of the goals with this coverage is providing that level of coverage to address that particular priority population. But obviously this spans the scope of pretty much every priority population that we have addressed or that we have talked about. Michael.
Yeah, the other prioritized population, which again was addressed last time that we presented, is the LGBTQ population, because currently the way the policies are written, you have to have a diagnosis of infertility, and same-sex couples do not have that diagnosis. So I see this in a lot of other plans. I think it's inadvertent. I don't think it was intentional. by anyone. I'm going to hope that. But so there's a couple of different priority populations when you take a look at these guiding principles that are impacted. So one is the low income, and the other is the LGBTQ population, which currently does not have access to any of these benefits, or single people for that matter.
Right.
That's all.
So to that point, what we have on this slide is a multi-year roadmap that we proposed last year, but we added one piece. And to Michael's point, the far left column is removing existing barriers to care. So currently, within the medical guidelines or medical summary plan descriptions for each of your carriers, coverage for infertility services is only provided when a diagnosis of infertility has been established. And what that means is essentially excludes women, single women, and women in same-sex couples without male partners, as well as same-sex male couples as well. So to have a diagnosis of infertility, you have to be in an opposite sex partnership and be, I think, Michael, trying to get pregnant for a certain duration of time, right? And I think that may vary by carrier, but it's, what is it, a year or 6 to 12 months. But without that, you can't access any of the fertility benefits even currently offered. So even outside of adding these IVF or assisted reproductive techniques, the ARTs, we would recommend removing the infertility diagnosis requirement across all Pebb plans. That's Mercer's recommendation, even outside of adding coverage for the ARTs. We actually receive feedback from your carriers on whether it would make more sense to take the current clinical guidelines and requirements and modify them to ensure we're including coverage for same-sex couples, single people. Michael brought up a good counterpoint, though, that if we modified the infertility basically definition to include coverage for those prioritized populations, we may be reverse discriminating against heterosexual opposite sex couples. If you keep the requirement of having infertility for opposite sex couples, but remove it for same-sex couples and single people, you almost create the case of reverse discrimination. So actually, our recommendation is to remove that requirement entirely and just say you can access these fertility and infertility treatments without a diagnosis of infertility.
Yeah. And Nick, I just want to, pipe in, opposite sex couples are likely not going to go through all of this. It's painful. It's costly.
Yeah.
A lot of hoop jumping. So I don't think anyone waltzes into this, particularly with the IVF or ART, lightly. I mean, it's and you have to have a physician or more than one physician that endorses that for whatever reason. So I just think we want to be careful about, like Nick said, the reverse discrimination aspect. So a lot to consider here from all aspects.
Yeah. The middle column is another recommendation, obviously, is for this upcoming plan year to add the coverage for the ARTs. And effective 1/1/2022, we add coverage for IVF and the host of other ARTs that are associated with or surrounding advanced fertility treatments. For 2023 and beyond, we want to evaluate the entire suite of inclusive family planning benefits. So this would include the adoption, surrogacy benefits, egg freezing, sperm freezing or storage rather. I think it could be on our roadmap, but quite frankly, there's a cost associated with all of these benefits. And so for this upcoming year, I think the majority of members who are going through this would receive the greatest amount of benefit. So bang for your buck, so to speak, for the ART coverage. And then we can talk about adding coverage for some of these other services as we move down the road, especially with the emphasis on health equity and making sure all the prioritized populations are addressed, including folks that want to do adoption or surrogacy, whatnot. All right, just want to make sure. Yep,
hey,
go ahead.
I think also, maybe you're going to get into it. I think there also could be pent-up demand And so that's why we want to kind of start with, I mean, just lifting the infertility diagnosis and then allowing for ART would help several. And then also the benefit plan design, as Nick described it, could help a couple of your prioritized populations here. So, it's don't, we don't want to ignore the options of surrogacy and adoption, but also just having a line of sight to that cost is important. So I just wanted to reiterate that. Thanks.
Yep. So here's our recommendation. We are proposing a $35,000 per year limit on these coverages. So total benefit, or benefit rather, not a limit, but a total benefit of $35,000 per year. Broken out, what we typically do is break out the medical piece and the pharmacy piece separately. We find that the pharmacy benefits are typically higher cost, or pharmacy costs associated with fertility treatment is typically higher. So we have more emphasis on the pharmacy benefits. This would be carved out. So a member could receive these $35,000 worth of benefits outside of their normal, I guess, cap on other services. So these would be covered just like any other service, up to $35,000. The total estimated cost impact for this is approximately $5 million, with about $3.5 million of that being associated with the treatment itself. The additional $1.5 million would likely be from increased pregnancy costs related to the treatment. So if all goes well, right, there are associated costs with pregnancies, including the possibility of complicated pregnancies. So one of the issues or side effects of IVF treatment is some members will need to do, as recommended by their physician, this is all clinically relevant, will need to do double or dual embryo transfer as part of IVF. Generally speaking, we would recommend single embryo transfer because it reduces the risk of having multiple births or having twins, essentially. But in some cases, it is clinically appropriate to do the dual or double embryo transfer. In that case, we would expect there could be some associated costs with pregnancy or NICU costs, so neonatal intensive care unit costs. Generally speaking, twins and multiples have a higher chance of being in the NICU and associated higher costs with that. So within that $1.5 million of pregnancy costs, we do have an underlying assumption that some of those pregnancies will be complicated and higher costs than what we normally associate with a pregnancy.
I want to just clarify something, Nick, that we're not against multiple births.
Yeah, right.
The point is actually the American Society of Reproductive Medicine recommends the elective single embryo transfer. So that's their clinical guidelines, because having multiple births increases the risk. So increases infant mortality, increases the NICU, increases the number of potential developmental disabilities. So this is we're reflecting what the American Society of Reproductive Medicine recommends. So nothing against anyone who's part of a multiple birth here, but in this situation with the assisted reproductive techniques, there's just so much risk involved, and we're just basing this on the American Society of Reproductive Medicine and their recommendations on having the healthiest birth possible for an infant.
Yeah. I'll just add that, these are not Nick Albert fertility recommendations, right? So these are based on all the research that Michael and I did throughout this process. So I guess it would be helpful to walk through some of the underlying assumptions on how we got to the $5 million. We have an internal tool at Mercer that helps predict the costs. And so within this tool, we have data from great websites such as Fertility IQ. We have great data from some of our vendor partners on the average costs of all of these various services, the average costs of pregnancy, the average cost of complicated pregnancies. So all of these sort of input into this tool. And then what we do is look at Pebb's population, and we look at how many female Pebb members are there between the ages of 18 to 45. So that's kind of obviously the subset of the population that we look at when we think of who will utilize fertility benefits. So within that, there are about 25,000 female Pebb members between 18 and 45. We assume about 6.6% of those will use fertility treatment at some point in their lifetime, so 249. And then what we do is we make assumptions about what kind of treatment will work for a given member. So out of those 249, some will go down IUI, and that'll work for them. And that's great for the plan and great for them because it's less invasive and less costly for the plan. The remainder will have to seek this advanced form of fertility treatment. So IVF, GIFT, ZIFT, all, going down the lines of the assisted reproductive techniques. Then what we do is just multiply by the average cost that we see with each course of treatment. So what we're doing is coming up with basically an average cost. So what we see across the average, of those seeking IUI, those seeking 1 cycle of IVF, all the way up to possible 2, 3, 4 cycles of IVF, the average cost is about $24,000 is what we're estimating for the cost of fertility treatment. And then we have the pregnancy costs associated with those successful pregnancies or successful courses of treatment, rather. $22,000 per normal pregnancy. Of those pregnancies, there obviously is the chance of complications. For the cost of a complicated pregnancy, we estimate that would be about $149,000. So overall, what we do then is take the IVF cost and the pregnancy costs, add them together, and come up with the estimate of about 0.6% of the overall composite rate, $5 million.
So I wonder if we should stop now that we've given you a lot of information.
Yep, absolutely. And I see Sean. I see Sean is coming off mute.
Yeah. First, I just want to say thank you, Michael, Nick, and your team for putting it all together. I know it's been a long time coming and a lot of research. Appreciate it. It's an important topic that, as you said, we intended to get to last year, but circumstances being what they are, we were delayed. So I feel like the proposal that you have put together is a really reasonable, kind of balanced proposal based on the needs of our members, the kind of general healthcare coverage trends out there, protecting us from like runaway costs that are, that could just, balloon into uncontrollable ways. There's a balance here of some coverage limits, but also adding in these new coverages, which are sort of gaps in our current coverage. And I appreciate you pointing, your recommendation about, inadvertently creating new inequities, and just kind of doing away with that possibility by simplifying the code a bit and making the infertility requirement obsolete. So I feel that this is a good proposal. It's a balance to me that strikes our needs of meeting our members' needs and also containing costs in doing so. So I really appreciate it.
I wanted to weigh in as well, and echoing what Sean's saying, I appreciate all the work too, and appreciate the equity lens on it. And I have a specific question on the lens around low cost. Does this proposal build in an increase in coverage for the IUI? I feel like I saw that is that on a later slide and it's just not here?
So we went down that road because oftentimes when we look at least in Mercer's modeling, IUI is typically included within this cost estimate, so to speak. We would typically in this $35,000 include IUI and these assisted reproductive techniques. Right now, IUI is already covered. So that could be actually a benefit decision for the board to consider as far as whether you want to include the cost of IUI within this $35,000. One of the reasons we propose $35,000 is it does give us some buffer, right? So the average cost of IVF is 20 to 30, and what we've seen, if you wanted to include IUI as a covered benefit under this $35,000, you'd be enhancing the IUI benefit because right now IUI is only covered at 50% cost share. So you'd be enhancing that benefit, but also still leaving room as a buffer. So that's, again, one of the reasons we did the 35,000 is not, to allow members to receive the right treatment and not feel like they need to, fit it in within the benefit limit. So that could be a consideration, Siobhan, if there was an interest from the board to move IUI treatment within this. It wouldn't change the cost estimate. It's just such a minimal component of the overall cost when we're looking at ARTs. We would still feel comfortable with this estimate if you wanted to move the IUI coverage.
And if we move the IUI coverage over here, that would mean that people would not be paying 50% of the cost. They would have a cost share that was actually reasonable, so that folks, whether they're making $40,000 a year or $100,000 a year, people could afford the benefit.
That's right.
And you're saying that's not currently what you have written up here, but the cost would be the same if we made that decision to move it over.
Yeah, so I did play around with our modeling and I did, some various assumptions on the underlying treatment costs of IUI. It's basically a rounding error within the 3.5 million, just because we only think 55 members would be successful and use IUI to begin with. And at $1,000 to $3,000 per pop or per cycle, it just doesn't make a difference as far as the overall cost goes.
Got it. So I mean, from my perspective, it makes sense that would also become a low cost option for folks, particularly since it is less expensive and less invasive to begin with, and that's where people would start. Yeah. And I just also want to say I appreciate the Pebb members who wrote in, and also just want to note the other Pebb members who didn't write in, but who have spoken with us over the past few years around wanting us to increase access. And this is from folks who have been diagnosed as infertile, as well as same-sex couples and single folks who want to have children. So I do appreciate the equity lens on this and hearing from people.
This is Michael. I just wanted to say that it will be really important if the board continues to go down this path and approve the roadmap that we're discussing, that the language around this is going to be really important. And I was just looking today, for example, most people are familiar with the term artificial insemination, but some people take offense at that. They want to use the term alternative insemination to describe IUI. And then even just the way we describe it, we're just going to have some sensitivity around individuals who may have, identify as gender non-binary or some other gender identity, but they are the person with a uterus and fallopian tubes. And so just using that kind of terminology, I think is going to be really important, because it will also signal, particularly to your LGBTQ individuals and individuals that identify as gender non-binary, of the commitment of the board to that population. So communication is going to be, after Nick does all of his work on numbers, communication is going to be really important around this as well, which we're not doing right now, obviously, because we wanted to get the numbers and the concept in front of you.
One of the things that I'm guilty of in discussing artificial insemination in general is IUI is one form of artificial insemination. So IUI is the implanting of the sperm in the uterus. There's also possibilities of implanting it within the cervix or fallopian tubes. Artificial insemination covers all three of those, even though IUI is the most prominent. So I just wanted to call that out because I've been also guilty of that. And Pebb covers the whole gamut of artificial insemination, not just IUI. So I just want to call that out. Okay. So any questions on the proposed benefits, the proposed cost?
I just had a question of whether we're looking at making a motion around this today, taking action so that will inform our April discussion.
Not at this time. Okay. So I think we'll have some follow-ups that we need to work out with the carriers. As you can imagine, this is complicated as far as how their clinical guidelines shape out. So we need to do more work with the carriers, including talking from a clinical standpoint on how they can best shape this. And let's just go to the next slide here for some of these considerations that we asked about. For instance, assess the eligibility, the coverage for out-of-network providers. So that would be something the board will have to weigh on. Whether we want to provide this for the ART coverage for out-of-network providers as well as in-network providers. Mercer's recommendation is only to provide this benefit for in-network providers. The other point is the member cost sharing, on whether there is any member cost sharing. It sounds like from at least Sean and Siobhan's perspective and Mercer's point of view as well, that this is provided at no, regular member cost sharing, right? Deductibles, copays up to the $35,000. A lot of times what we see is, $35,000 with 50% coinsurance. But I think that, from Mercer's point of view, does not address the health equity side of things, because at the end of the day, the member would still be responsible for $15,000 to $20,000 worth of costs. And so we didn't feel like putting a coinsurance on these benefits was appropriate. We felt like just covering the full gamut of services would be our recommendation. And then ESET. So I already alluded to this a little bit, but the elective single embryo transfer. This is clinically, this would be the American Society for Reproductive Medicine's recommendation on only limiting IVF to ESET coverage, so the single embryo, to prevent the possibility of multiple births. Not that we're against multiple births, as Michael said, we're not against that, but they do have associated costs. They're typically more higher likelihood of needing NICU treatment than single births are.
Well, and increased risk. Sorry, just the actuary is talking about cost, but also risk, increased mortality and morbidity in infants. So it's the financial side and the human side. And again, plus that's the ASRM recommends that as well. So it's based on best evidence-based guidelines.
Yeah, and so just a little follow-up on that point in particular. It does feel like in that case, it's kind of not really about the cost, because the benefit of doing two at once is that you're more likely to have one of them or I assume that's why they do it. In which case you don't have to do it again. Whereas if you do one at a time, you may be doing multiple rounds, right? And so there's a cost of doing the multiple rounds as well, although those are probably dwarfed by the cost of a pregnancy, a high-risk pregnancy that ends up in a kind of emergency situation. But it feels like the main point there is it's safer, and dollars and cents, it may come out kind of almost a wash maybe, because there's cost of doing one at a time, but it's just safer. Does you agree with that, or?
Yeah, and we received feedback from all three of your medical carriers that theoretically, well, I guess not for this one, for the Centers of Excellence, but they would not recommend limiting coverage to ESET. They really feel like it's up to the patient-provider relationship to discuss this, the pros and cons of doing the single embryo versus the double embryo transfer. Again, a lot has to do with the member's unique condition and how, whatever the fertility diagnosis is, but also age plays a huge factor in whether the treatment is successful or not. And so their recommendations, and Mercer would be inclined to agree, leave it up to the in-network providers to make this decision in conjunction with the patient. And I think that would provide the best outcome in this case.
Okay.
Yeah.
And even saying something that, like, based, the evidence-based clinical guidelines, such as American Society of Reproductive Medicine, which has guidelines both for providers and for patients. So again, that could be part of the communication piece that goes out.
Yep. The last piece that we asked about were centers of excellence. So sometimes with these type of benefits, plans will dictate that members go to see, provider XYZ to ensure that, all the right clinical guidelines are followed. That we know that provider XYZ will follow all of these various Society for Reproductive Medicine guidelines. None of the carriers have COE related to fertility. So I think what we can do is just simply limit it to their in-network contracted providers. And I think that will function really well still, even without the COE aspect of it. I think their in-network providers are obviously very knowledgeable about all of the clinical guidelines that they need to follow. Okay, so the outstanding issues, and I think we have some feedback from a number of you, but we are still working with Kaiser on what type of plan that they can mimic. So obviously we don't want to create a disparity between Providence and Moda's fertility benefits versus Kaiser's fertility benefits. And also ultimately too, we don't want to create any anti-selection issues. If Providence and Moda have a great fertility benefit and Kaiser doesn't, we don't want to drive membership away from Kaiser or whatnot. So we're working with Kaiser still on some estimated costs and premium impact for their benefit and what that would ultimately look like. The board, and we can talk about this now if we're all inclined, but we need to decide upon the benefit maximum, yearly or lifetime. What Mercer has proposed is a yearly benefit maximum of $35,000. So it would reset every January 1st. So a member could have new benefits each year. Member coinsurance or cost sharing. So it sounds like that is a no on the member coinsurance or cost sharing outside of just normal, deductibles, copays, things like that, but not the additional 50% coinsurance that we sometimes see. And then the last one is to provide coverage for out-of-network providers, which it sounds like we want to take Mercer's recommendation again and just limit it to in-network providers. Any additional thoughts or follow-ups that Mercer should take back as we're sort of designing a final benefit and cost impact?
Hey, Nick, the other piece is the removing the requirement for a diagnosis of infertility. Sorry.
No, that's absolutely right. So this is just for the ART coverage. I think.
Gotcha. Sorry.
No, I think that's a great point because I think the removal of the requirement of infertility, I think, would be without cost. Mercer would not estimate a cost impact or a premium impact. To Michael's point, people aren't just vying for these services out of thin air. Like you have a reason to do that. So we would add it to the plans, and I think that would be completely reasonable without any premium impact. But
this is Kate. I don't have any additional questions. I was going to ask about what Michael just brought up, so I think I'm good. And actually, Nick, you got in front of me on whether or not there'd be additional cost for just removing the infertility piece. I'm assuming we're already covering the pregnancy. For
Yeah.
couples, they've had to just or individuals, they've had to just bear the cost of the fertility treatment on their own, which has been unfortunate. So I think that answered my question.
Yep.
Thank you. And thank you for all your work and digging into this. I know this has been a lot of work, and I think it's very beneficial to keep this conversation going. I'm very supportive of it.
So, Kimberly, if it would be helpful to do board motions on any of these, we can do it now, and we can take that into consideration, and we can sort of check the box as we go. Or we can simply vote all at once in the April meeting. Whatever the board would like to do. I think it would make sense to vote on some of these various components. If we do want to vote today, we're not going to vote on the whole benefit package of fertility, because that's there's still some details we need to iron out as far as with Kaiser in particular. But if we do want to go down the list here and just vote on any one of these issues, that's totally cool. Open to the board's feedback on that.
Well, and what I kind of would like is I would like it to then be kind of on record that we listened to all the member feedback that we were getting about fertility issues. And, we know that we lost a year due to COVID. And we apologize to all those folks that maybe that magic window was closed for them. So I think it's appropriate for us to vote on pieces of this, but obviously I'm the chair, so it would be someone else would need to bring up some motions.
Can I ask a question? What would the vote look like? So this is Kate, sorry. What would the vote look like? Is it vote to continue looking at it, or would it be to actually vote to include this? Because I do have some concern about not having, I'm going to use the wrong word, parity between the Kaiser plans and the Providence and MODA plans, because I do have a concern about that. And so I want to make sure that we don't get the cart in front of the horse on that piece. So what would the vote, or what would we be voting on now? And maybe that's a question for Nick.
You're on mute, Nick.
Right. These three issues on the screen, the benefit maximum, the coinsurance, and out-of-network providers. So if someone makes a motion to accept the $35,000 per year benefit maximum that Mercer recommended, we can move forward with that piece. And Kaiser, for their credit, has already provided that they're looking at exceptions to their current filed fertility benefits that they have with the state. Obviously, they're fully insured, so they have specific riders. So Kaiser's already looking into that piece for us. So I think we can make in confidence these three pieces without, going into the further confirmation of all the details.
Got it. Okay, I feel better about it. And I apologize. I had to do two things at once while my daughter's Zoom music class meeting link wasn't working and email teacher. So I apologize if I missed that. Thank you.
And Nick, on the third bullet, has there been some analysis on just the network coverage of in-network providers with our plans?
We have not done that, Ollie. Yeah, okay. We're under the assumption that they have enough in-network fertility providers, but we can certainly, that can be a follow-up if the board is interested.
Okay. Thanks.
It's not a large subspecialty, I will just say. They don't grow on trees, so there's not a lot of them, Ollie. But we can certainly, part of our discovery we could be asking the carriers, how many do they have that are, specialists, subspecialists in this area.
So I know I made comments earlier, and I feel ready to make a motion on the benefit maximum that Mercer recommended, as well as the member coinsurance or cost sharing. And from my perspective, that would include moving the IUI into or all of the art that's currently covered. I think you were pointing out that it's not just IUI, but that that wouldn't continue at 50% of cost, but that would be the cost sharing that's currently set up for the plans. So I'm comfortable making a motion on that. I do want to have a bit of a discussion as a board on the coverage for out-of-network providers. That does strike me, I mean, from where I sit, that it would then become quite costly if someone went out of network, because there's 30% co-insurances, for example. And but I feel like we should talk a minute about that. So I'm just making a motion right now on the $35,000 benefit maximum that's what we should look at for April and have the plans look at, as well as the member co-insurance or cost sharing that we currently have with the plans.
And this is Mark. I'll second that.
Oh, welcome, Mark. Any questions or comments? Okay, so it was a kind of a lengthy motion. So, Kate,
I'm happy to restate it. Do you want?
I think we have it because we're recorded, but I just was, Kate, before I start roll call, did you need me to repeat the motion, or are you guys good with me just doing a roll call?
Can we just repeat it really quick to make sure that I heard it the same way you did and the rest of the board did? I know I'm probably, and I know it's on record. I just want to make sure that I'm voting the right way.
Okay, so Saban has made a motion that we accept the benefit maximum of the 35,000 that Mercer had shown on the previous slide. And then the member, so I'm going to get mixed. So we're not going to do the member co-insurance or cost sharing, correct? Because that would then increase the amount.
So I'll clarify.
Okay.
So yes, my motion is to do Mercer's benefit maximum of recommended of 35,000, and then on the member co-insurance or cost sharing, that we take Mercer's recommendation, which is what the plans currently have around co-insurance or cost sharing, that the services are in line with those, including the services that are already covered through IUI, the art services that the plans cover, so that they're not more expensive than what the plans currently are around co-pays and cost sharing. So I was making motion on those two pieces and not on the third one around the coverage for out-of-network providers.
Okay.
One thing I want to clarify on Siobhan's motion is specifically the IUI. So I think the motion is actually to move artificial insemination, which includes IUI, into the coverage for the $35,000. So artificial insemination, keep the 6 limits that are currently in place, but move it into the coverage under the $35,000, fully covered, no 50% co-insurance.
That's correct, because we want those benefits to be in line with the other benefits we're talking about expanding.
Yep.
Okay, so now do we have any questions or comments on that motion? Okay, Kate, how would you like to vote?
Yes.
Thank you.
Thank you, everyone.
Kim Harmon?
Yes.
Thank you. Sean Parkman?
Yes.
Thank you. And Mark, you seconded?
Yes.
Siobhan, you were the first motion. Jeremy, were you able to join us? Okay, and all right. Any opposed? All right, Siobhan, thank you for working that through for us. We appreciate that. And Mercer, thank you also for all the work you have done digging into this. And I want to really make sure that the important piece that all of us are working towards is this health equity and being very inclusive and not creating barriers for others. And I think that we attempted that today and did a really good job. And we need to just keep that, keep doing that with things when we are making decisions for all of our members.
Absolutely.
And I do think we should revisit the question on the coverage for out-of-network providers in April, and to Ollie's point, just get more information.
Yeah, I think to Michael's point earlier too. I mean, one of the focus of the health equity populations is rural population. So how do these benefits align with the availability of providers in some of the rural communities within Oregon? So we'll have further information on that. We'll include that as part of one of our round 3 questions that we'll release to the carriers this week. Okay. And here I was looking at the time and I was like, wow, we have a lot of time to talk about, 20 slides, but here we are. All right. So I think we have only a couple minutes left. The last piece that we want to talk about today are the transgender benefits. And this is a follow-up, I think, to either the, what is it, Michael, the October meeting, one of the fall meetings, maybe the November board retreat, but getting the benefits to be aligned with the WPATH standards of care. Oh, in the September board meeting, it's right on the screen in case for those of you following along at home. The September board meeting, the board made a motion based on Mercer's recommendation to proceed with pricing out the impact of modifying the medical coverage policies to explicitly include coverage for all of the services within WPATH, except for the 2 items here, fertility and infertility, which we're actually addressing obviously today. But obviously then there's the cost of services for travel and lodging related to international centers of excellence. Effective 1/1 of this past year, Kaiser did modify their clinical criteria to ensure it's comprehensive and provides coverage for the gender affirmation. They did so with no premium impact. For 1/1/2022, Mercer priced the expected costs of aligning Providence and MODA to the WPATH standards of care, and we priced an impact of 0.05%, which would be about $350,000 split between Providence and MODA. So that's overall a combined impact between those plans, but we estimate actually it'd be about a 0.05% impact, just with some of the added benefits that are needed to be covered by those coverages or those plans. We will incorporate this because I think the motion was already set and forth. I don't think the board needs to vote any further on that. We'll incorporate that 0.05% as part of the cost included in the composite rate for April's meeting.
That's right, Dick, because there was a motion in September that gave Mercer direction to do what you just described. So once you go to take a look at the overall renewal, that's when you will be explicit in bringing this out. So we followed through with what you asked us to do in September around this topic.
All right. So with that, next steps. So in April, I think is going to be not any more lengthy than this, but some more details on the fertility benefit design. We'll include the follow-ups for the out-of-network piece. We'll include the follow-ups within the fertility section about Kaiser. So Kaiser's premium impact and Kaiser's possible plan design. And then we're also having further conversations with Providence and MODA to discuss and make sure they can administer the plan as set forth by the board today. So we'll have more feedback from them and whether they have any additional recommendations on ways we could either, improve the benefit or make it a little bit more seamless from a member perspective. And then we'll obviously have the final round 3. So these are the best and final offers for both the admin fees and Kaiser's status quo renewal. Obviously, there's a cost component to Kaiser that will have the option to elect their fertility benefit design, but we'll also have their status quo 2022 final renewal. The other piece is the Cigna portion for Providence. So we're working on that, validating their savings estimate internally right now at Mercer. So with that, that concludes the Mercer presentation for March. Any questions or commentary?
Thank you.
Thank you. Lots of good stuff. So Ali, I have a quick question. So can we flip the break and do the break before the Pebb admin fee increase, or
Yeah,
do we?
absolutely. Yeah, we can definitely do that.
I think my team, I'm reading some body language of my few cameras that are on, and I think maybe let's take a quick 10-minute break, and then we will get back started. So please don't log out. Just turn your cameras off and get yourself some stretch. See you back in 10 minutes. Thank you. All right. It's 11:35 and we will get started again. And it's all yours, Ali.
Thank you so much, Kimberly. Okay, Pebb administrative fee options. Just wanted to give the board an update on our operating budget and our administrative fee. The Public Employees Benefit Board, other funds revenue pays for Pebb administration through an administrative assessment added to core insurance premiums. So that includes medical, dental, and vision premiums. By statute, Pebb can collect an amount that equals up to 2% of total premiums to meet administrative and operational costs. The administrative fee is the only revenue stream that we have that fund the board's operating expenses. The fee was increased for the 2021 plan year to a 0.90% administrative fee after several years of staying stagnant. This increase has covered our current budgetary expenses and has sustained a working capital balance, which is basically an ending balance sufficient to cover Pebb's operating expenses in plan year 2021. So for plan year 2022, there are going to be new bodies of work that will exceed our current administrative revenue stream, requiring an increase in the current administrative fee. These bodies of work include the second phase of the joint Pebb-OEB benefit management system replacement project, which is currently a policy package under consideration in our legislatively adopted budget. Funding Secretary of State audit findings in the areas of communications. You'll remember they had several recommendations for improvement, communications being a big one, enhancing open enrollment resources, developing member education tools, and we've been working on some options there, specifically with our PMAC committees and worksite wellness. And then performing a program-wide claims audit and clinical audit. This is something that's recommended to do every 3 to 4 years. We completed one about 5-6 years ago. Unfortunately, I mean, we would love to do them every 3 to 4 years. Unfortunately, they're very, very costly, about $800,000 between the two. They take about 5 to 6 months to do. The auditors were pretty adamant about the need to do that. And so we're going to pursue the cash and our expenditure limitation to do that. And then pharmaceutical costs and hospital payment cap audits. Those are new audits that are kind of outside the scope of our current service budget level that kind of are new requirements of the things that we need to do. So supporting a policy position from our 2023 policy package that is titled Advancing the Coordinated Care Model. This position would have a number of duties such as staffing our health equity work group, helping to onboard local governments interested in participation in Pebb and OEB, and staffing, participating on other OHA committees. We are requesting board action today. Pebb staff is requesting an increase to the overall administrative fee from its current 0.9% to 1.15% for the 2022 plan year. This increase will allow Pebb to fund the new bodies of work listed above that support the mission and long-term goals of the board and fund an appropriate response to the Secretary of State findings. The administrative fee will continue to be reevaluated each year to ensure appropriate funds are maintained for funding Pebb operating expenses. You'll remember that we kept the administrative fee very low for about 3 or 4 straight years because we had accumulated too much operating fund balance, and we were actually getting penalized by the feds for having too much of a working capital balance. So we increased that last year to the appropriate level. We want to be careful in monitor that balance. So we obviously don't want to get penalized and have any payback. So it is really important that we reevaluate this each year and stay under that working capital ending balance. So is there any questions or concerns or anything else I can answer?
This is Siobhan. So I don't have any questions coming up. I know that Pebb has taken on additional work from the Secretary of State's audit, and there are just a number of requests that we've had as a board too that have been driving operational costs. And I am comfortable making a motion that we increase the administrative fee for Pebb as written here from the current 0.9% to 1.15% for the 2022 plan year.
Thank you,
This,
Siobhan.
this is Kim Harmon. I second that.
Thank you, Kim. Any questions or comments? Okay, we'll go ahead and do a vote. Kate Nass?
Yes.
And Kim is the second. Sean Parkman?
Yes.
Mark Perlman?
Yes.
Siobhan was the first. Jeremy, did you join us?
I did, yes.
Oh, thank you. Did you want to vote on this motion?
Oh, I said yes.
Oh,
please.
oh, thank you.
Okay, yes.
Thank you. I appreciate that. Any opposed? Motion carries. Thank you so much. And thank you, Ollie, for really staying on top of that. And I do remember when it creeped up and we got ourselves in a little bit of hot water. So we do want to review that yearly.
Yeah, thank you.
All right, so next up is WebMD, Healthy Team, Healthy You, and I'm not sure who's presenting.
Good morning, everyone. This is Maureen Convey from WebMD. I'm joined today by Melissa Voigt, and I'm going to pass it over to her to kick us off.
Thank you.
Hello, can you hear me? This is Melissa.
Yes. Yep.
Okay, great. Well, thank you for having us today. We are excited to share just some great updates with the Healthy Team, Healthy You program. I'm Melissa Voigt. I am our Vice President of Client Experience with WebMD, and Maureen Convey, who you just heard from, is our Strategic Account Executive that has been working with the Healthy Team, Healthy You program. And what we wanted to do today is just share with you an update on how the program is going and the exciting future that we have with the program. But first of all, just wanted to share a bit of history. As you guys may know, WebMD is probably a new name that's coming to you. Previously, we were working with you under the company name Staywell. And Staywell was actually acquired by WebMD almost a year ago today. And so we are really excited to be able to share, because of this acquisition, just some of the new enhanced features that the program will have. But, you know, we have been partners for many years. We greatly value your partnership. And we feel like the acquisition with WebMD is going to, you know, just further enhance the Healthy Team, Healthy You program. But before we shared with you, you know, the future of the program, we also wanted to take the time to take a step back and share with you the great successes that we've had so far with the program, taking a look back a couple years. And to do that, I will turn it over to Maureen. So Maureen, I'll pass it over to you.
Great, thanks, Melissa. So as Melissa stated, we just would like to take some time right up front here just to provide a very high level overview of the core services that are available to the HTHU participants. And if you can go to the next slide, please.
Can I ask really quick, this is Kate, is other people seeing the slides, or is it, I mean, I can follow along on my own materials, but for some reason I just see Ollie, which I love seeing. Ollie, it's fantastic to see you. But can others see the slides and it's just on my end?
I can
I-
see.
I will figure it out.
And Kate, I had that problem a little bit ago, and I
My
just
computer keeps
left
cutting out.
and came back in.
Okay, I will figure it out. Thank you. I just wanted to make sure everyone
No
knew.
worries.
I didn't mean to interrupt you.
No worries at all. No problem at all.
Thank you.
Okay. Now I just need to get back to the presentation. Melissa, are you able to share that? I don't see it.
So we can have Rose share her screen if needed.
Okay, thank
somehow
you.
it got knocked
Sorry
off Rose. Yeah.
Oh, great. Thank you. So the slide, oh, there we go. Perfect. Thanks so much. So again, we just want to talk about the core services that are available right now to HTHU participants. So first off is sessions, and that's our e-learning activities. So that allows participants to learn via e-learning on a variety of health topics, and the experience is participants review educational material, they participate in a game or quiz activity to test their knowledge and complete a goal. Challenges offers the opportunity for individuals to have a goal to attain each day, and it can also look at progress that other folks have made on a leaderboard. So we have fruits and vegetables, strength, and steps. Activity trackers, that gives people the opportunity to track on their own. So we have 31 different trackers that people can take advantage of, from limiting their salt intake, meditation, to increasing their water intake. Then a variety of educational resources, videos, articles, healthy recipes, and then device integration, which is with a wide variety of wearable devices, including by far the most popular, which is Fitbit. So what none of us expected in 2020 is how our world was going to change. And so probably for all of us here, we had to adjust our world. And so did we for the program strategy. So what we did is we took a step back and looked at how could we still engage the population, even though the world had changed and people were working remotely, they weren't having the collaboration at the work site. So Laura Jacobson, the dedicated program coordinator, really took this opportunity to take a step back and look at the strategy. And what we have put forth in 2020 is a variety of webinars that you can see noted there, both live presentations, and then the recording is available on HTHU On Demand. Developed a Healthy Teams Healthy newsletter, and that will be offered each month, and that started in December, and that aligns with the monthly webinar topic. And what we can see is a lot of registrations from the newsletter go right into the webinar, so that's great to see. Coming soon, virtual wellness breaks. So getting people to engage in light activity, as probably a lot of us are sitting more than usual. So to be able to engage people wherever they're at and get some movement. And then virtual worksite presentations, that's coming soon also, to really get more awareness of the H2HU program at the local level to drive engagement, along with providing COVID-19 resources and Beyond Well podcasts. Those are mental health podcasts that cover a variety of topics. They're short podcasts like anxiety, creating balance, coping mechanisms. But I think what's really interesting on this slide is just if we look at webinars in particular, we had over 6,000 people register for webinars, and those started in October. And we have 4,814 that have attended, along with, you can see, anywhere from 200 to 400 views of the recording. So definitely we've resonated with the population. This is a way that they've been are engaging with us. And the sleep topic in particular came from a direct feedback that we heard from Pebb members. So then looking at the semi-annual report, and so what impact this program has made. So looking just at straight utilization of the platform, you can see the breakout of return visitors and new visitors. Team activity. So people have the opportunity to join teams or be a team of one. So you can see there were 1,290 active teams during the program period. Of that, 55% were a team of one, and that pretty much aligns with our book of business. A lot of people like team of one. And then we did see 14% of teams have at least 2 people, and 11% had 3+ people in the team. And so we definitely know peer support is important to many people. Challenge tracking, again, when we talk about activity tracking, the top 3 popular ways to track were physical activity, looking at active minutes, steps, and then distance. Then I think this is an interesting snapshot of physical activity and then the average minutes per week by affiliation. So you can see there that the National Physical Activity Guideline is 150 minutes per week. And so the red line shows you the number of users, and then the blue line is the average minutes per week. So you can see in most cases, we are above the national guideline. So that's really great to see, whether that got people moving through challenges and they did it with a team, or if they did it individually and they were just tracking their minutes. And then looking at physical activity. So we had among the participants reported an average number of days of physical activity increased by 42% across all levels. So we have level 1, level 2, and level 3, and people have the opportunity to choose which level they want to participate in. Strength training, the number of days spent strength training increased 74%. So that's great to see. That's one where people tend to struggle with. Healthy eating, so that consumption of fruits and vegetables, making sure you get those servings, that increased 35% among the program participants. And then weight, 65% of the participants reported that the program helped them better manage their weight. And if you look at that and you see the increase in physical activity minutes, that's a great scenario to have in place. And then finally, satisfaction, I think is really important. Word of mouth helps generate buzz about the program, and program satisfaction, very high, over 95% rather, reported that they would recommend the program to a friend. And so that's something we always like to see, those numbers high, because again, word of mouth really helps with engagement. So those were just some of the key data points we wanted to share today. And as Melissa had mentioned in the beginning, really excited to talk about WebMD1 and where this platform can take the HTHU program. So I'll pass it back to Melissa.
Thanks, Maureen. Yeah,
Can I ask a question before we go on?
Yeah.
Oh, sure.
Did I see one of the slides, or maybe I was misinterpreting, about just like enrollment over time?
We have not shared that, but we certainly can jump to that. We will be going to that, but if you
is it later?
there,
yeah.
Yep, it is.
I'll wait.
Okay. And actually, that's okay. Let's go ahead and jump to that, because then we can talk through a little bit more about how we're going to be enrolling. So apologize for my scrolling. With enrollments over time. So again, we've been partners for quite a few years, but from a look back perspective, we went back to 2018 in terms of how many people we were participating. So to refresh people's memory, we are currently on a per participant fee structure. And so in 2018, you can see that we had total enrollments, which means that they have enrolled in the online platform. They have enrolled in one of those levels that Maureen was talking about. We enrolled about 8,600 in 2018, staying pretty consistent in 2019. And also wanted to share from an enrollment perspective, we did have a team of individuals that were working on site and were hosting in-person events to help with the enrollment structure to essentially, have that live invitation to get people to enroll. And in 2020, obviously our strategy needed to change due to the pandemic and not having the ability to do in-person enrollment. So The first part of the year, of course, when we were starting to transition, we had lower engagement numbers, but when we, after, we were able to get our grounding and find ways to engage the population remotely, we've started to see success. But what you'll see in 2020 is we've had to, essentially change tactics altogether to engage the population. So early in 2020, enrollments were a bit lower. And again, how the fee structure is set up is that how the fee structure is set up is that the enrollments are only happening if they're enrolling in the level 1, level 2, level 3. So we have started to take a look at, like Maureen was sharing, the webinars and some of those other tactics to engage the population. But from an overall fee perspective, even with the webinars and some of those tactics that we're taking, those are not a part of the fee structure, which we'll certainly talk about changing that fee structure of an all-inclusive model when we go into kind of what's upcoming and new and fresh. If there aren't any questions on this, and we can certainly revisit it once I share, more of the plan of how we are going to work, going forward, which we're extremely excited about. So first of all, as you all know, the HHU program, it's on our legacy Staywell platform. It's called the My Staywell platform. And we, after the acquisition, the WebMD1 platform, can you guys hear me okay?
Yes, we can. I think somebody needs to mute their mic because what you're picking up is that somebody's talking and it kicks in.
Okay, good. I just wanted to make sure that you guys could all hear me, so I appreciate that. So we have the new WebMD1 platform, which we feel like is a very robust platform that helps to provide a very holistic experience. So there's a lot more features, programs, as well as just all of the great WebMD content that you would expect. In addition, we're able to drive deeper connections through segmentation and personalization. And we'll talk a little bit more about how we will actually personalize the program experience to the participant. And then there'll also be, way for champions to engage as well. So we have gone through a full demo experience for Margaret and Glenn, but we would be happy to do that with anybody here. But one of the great things that we have is when a participant enrolls in the WebMD1, to help personalize it, there's a couple of different ways we can personalize it, is any information that may be coming over on the eligibility file, anything we already know about the participant, but then we're also able to have the participant select what really interests them and what would they like to get out of the program. And this helps to personalize the platform experience as well by recommending programs that are of interest to the participant. So they can select, any 3 of these options to help personalize that. Once they've onboarded, similar to the levels that we have with the My Staywell platform, we have a daily habits program. So again, previously on the My Staywell platform, there were 3 different levels that the participants could progress through. Daily habits is a similar, I would say, but more robust version of that, meaning that we have it's essentially a digital coaching experience. And we have lifestyle programs as well as chronic condition programs that are available to the individual. And we have up to 16 programs available. So the participant can participate in as many of these as they would like to throughout the program year. But it's a way for them to focus on creating daily habits in their lives that will help with behavior change, essentially, that longer term behavior change. So for example, if you're doing a physical activity program, the digital coaching experience will remind you of some key activities that you can do and will check in with you if you haven't checked in with the daily habits plan. So it's a great, robust offering to keep people moving forward in those small things that they can do on a daily basis to help improve their overall lifestyle. In addition, we also have challenges. We know that offering these time-based challenges is a great way to engage the population. It also helps with, overall just camaraderie, within the workplace. And we do offer a variety of challenges, and the on-site wellbeing coordinator can certainly, work with the entire team to roll these out. But a couple of different options that we have, of course, are nutrition, walking, stress, hydration. A few of these are individual challenges that we will certainly guide participants through. But we also have team-based challenges. So the invitational is one of our most popular challenges, where it's a team-based STEP program that the individuals are able to join a team. And when they join the team, each week they get paired up. It's essentially a duel, a head-to-head with another team that is of a similar level to them. So for example, you'll never have the group that put all of their marathon running buddies in one group compared to those that are really just are trying to find ways to get a 15-minute walk in. So it helps to keep people motivated. And then if there is ever a time, which again, working with our on-site wellbeing program manager, if there's a specific topic that maybe we don't have within our catalog, we can always develop something specific for the HTHU program. In addition, we have what we call the creative shop. So I'm sure many of you are familiar with webmd.com and the wonderful content that comes with that, but we also have what we consider a turnkey toolkit that can help promote the WebMD1 platform and all of the programs. And so this creative shop essentially is going to give both the HTHU team, including the on-site coordinator, but if there are others that want to promote, the well-being program or just want some turnkey content that they can share throughout the workplace, that will all be available to you. And then in addition to that, certainly understand that there's going to be some custom needs to make sure that the communication and the outreach is going to drive the participation that we are all looking for. So we have included 100 hours of the custom communication support, where we actually have a communication specialist really dedicated to the OEB and Pebb team to help create an ongoing engagement strategy, but then also help deliver that. And there, I just wanted to show you a couple of photos of what this content looks like. So you can see it is highly professional. It is with all of the wonderful content through WebMD, but it is configurable as well. So this is where you have the opportunity to really make it your own and again, engage members in the HTHU program. In addition, we also shared that we would have a dedicated well-being coordinator to help really promote the overall culture of well-being. WebMD and Stay Well, we've been in the well-being industry for over 40 years. We've actually had on-site staff that have been embedded within our employer groups for well over that time. I think we have 110 throughout the country at this time. But what we know is that for well-being programs to really succeed, you want to make sure that you have, both wonderful tools such as WebMD1 for individuals to engage in, but you're also creating a culture of well-being and embedding that into the day-to-day workplace. So that's where things such as the webinars or the newsletters, some of that comes into play. But another key area for that is creating a wellness champion network. And, we certainly understand you have a champion network in place right now, but we think we can really help support, the growth and the evolution of that program as needed. Because that's one of the things that WebMD is very strong at is creating and maintaining successful champion networks so that these champions are able to bring well-being to life in the work setting. So whether that is in person or whether that is virtual, we've had success with both models, and this is where we would be able to provide continued support to build that culture of well-being. In addition to that, we all know that in order to have a successful well-being program, we need to understand how the program is performing on a day-to-day basis. And we would, another opportunity or an enhancement that I would say is that you would have the opportunity to take a look at standard reporting at any point in time. So this is an on-demand data dashboard, and there's currently over 20 standard reports available. And this is where we would there's two things, right? You have self-service. You can take a look at how the program is performing anytime that you would want, just to make sure that we're hitting the goals and objectives that we have with the program. But then Maureen will also be taking a look at the data to make sure that we are on track. So we can look at key performance indicators throughout the program and certainly measure those over time to make sure that, again, we're getting the engagement and that behavior change that we are looking to achieve with the program. So I'll pause there. Those are a lot of the key enhancements. We're, overall just excited to bring some of these key enhancements to the program to, really move beyond, the platform only, but create that holistic well-being program that, that I'm sure you and many of our other clients are looking to do. So I'll pause there before we go into the pricing. Any questions? All right, so from a pricing perspective, we've really wrapped it into a full program, into a per participant per month fee. So like I stated before, when we were looking at the per engagement model, we previously had a per engagement model, but what we know is that we need to have a lot of these pieces wrapped into the wellbeing program to make it successful. And so our team has, certainly worked with Margaret to understand, what this will, what it will take, and to continue to evolve the program over time. And so what we've included in the per participant fee, which is 25 cents per eligible per month, is the full WebMD1 platform. So creating the interest surveys, all of the daily habits programs, all of the challenges, educational resources from WebMD. And then all of this does come with, it's available desktop, it's available via the app, and there is the ability to integrate devices or other apps to make sure it's really easy for participants to track. In addition, we'll have that full-time dedicated program coordinator who will continue to engage from a culture perspective. So there would be 12 educational webinars, 12 newsletters, wellness breaks, helping to develop and manage that champion network, deploying things like the newsletters and communications to engage people in the WebMD1, and really support as needed across the departments. We would also include access to the online creative shop, which is all of our configurable engagement materials, in addition to 100 hours of custom communication support, and the full ability to view the on-demand reporting, as well as our telephonic customer service team. So again, I will pause there. Any questions?
Melissa, this is Margaret. How are you?
Good. How are you?
Good. I just wanted to chime in with a clarification in terms of what I think is a typo on this slide. When I look at the header, it refers to the pricing for October 1, 21 through September 30, 24. And I believe that refers to OEB, because for Pebb, we are doing the pricing on our plan year, which is the calendar year basis. So this would be for January 1, 2022 through December 31, 2024 for Pebb. And I just point that out, we've been working concurrently on this for Pebb and OEB, and I see on this slide that I think the dates are referring to the OEB plan year. So for the record, I just want to note that it would be in effect for the Pebb plan year starting January 1 of 2022.
Yes, Margaret, thank you. And I can see that in our notes as well. We have referenced OEBs. We apologize for that. Thank you for that clarification.
Yeah, absolutely. As I said, we've been working on both programs at the same time. So I think it was just probably an oversight.
Thank you.
So I have a few questions. So with pricing, I guess I'm confused. Is it a, pay per enrollment model, or is it built into like the premium, like regardless of how many people sign up, there's a certain administrative fee? Can you help clarify?
Yes, so it would be all inclusive, meaning it would no longer be a per enrollment fee. it would be all inclusive. So the goal is to have as many people as possible enroll and participate in the program. So there's no cap either. For the pricing, we estimated between that 5 and 10%, which is what we're seeing when we combine the enrollment in the program, but also what we're seeing for participation in the webinars and the virtual wellness breaks. So what we're essentially doing, if you think about it, the previous model really focused in on trying to get people to engage in the online program and the app, and then essentially it was per enrollment in that. We're wanting to take it a step further and say, yes, it is extremely important to get people into the platform itself, but we are also going to create the surround sound from a culture perspective and offer a lot more programming. And to do that and really have that model work out, it would be that the flat, the 25 cents per eligible per month.
So can you help me clarify? So we also use another service, Cascade Centers, to really do wellness webinars and so on. Like, how is this different? How would this be different or fit with that?
Yeah, and I'm not a Maureen, maybe you're aware of Cascade, or Margaret, we can talk through that. But if there are other programs available through other vendors, so I'll take it broader. If there are other programs, our wellness program coordinator can help to also streamline some of those. So even when we think about the WebMD One platform, the platform itself has some great features and functionality that it can almost be used as a wellness hub even. So if you wanted to direct people into the EAP program, or you have a disease management program, our platform is smart enough, and we would work with your different vendor partners to help create a holistic program for them. And then same if you have, even the educational webinars, if there's other services, we can help promote those as well. Or we can offer them specific to some of the different departments that are requesting. So maybe it is additional, but I apologize, I'm not exactly sure what services you have contracted through that vendor.
Sean, this is Margaret, just to give a little bit more of a distinction in terms of where there's some things that are unique to what HU offers. So, and that includes the online platform. I mean, the comprehensive online platform members can register on, engage in the ongoing wellness content for the program. The challenges they participate in are unique to this program in terms of, and we've run a couple of those already and had some pretty good engagement with Pebb members. We did a stress break challenge earlier in the pandemic, and had good reception from members on that. So some of those challenge functions where we engage members to compete in something for a finite, 3 or 4 week period with weekly content. And then also some of the different, I think, support and resources that are available for the agency wellness coordinators in terms of being able to roll out some of those competitions and challenges and program content to employees in the work site. I think, that's another strength I think that this program has that maybe is a little bit different from some of what we see with some of the EAP programming.
About how much is 0.25?
Yeah, so to clarify a little bit more on the cost, and we have this in a couple slides. So right now we are paying, our rate currently is $67 per participant. And one of the, I think it's the next slide, showed that so far for this year in 2021, we've had about 4,800 folks enroll. So at that $67 rate, that's coming in right around 325,000-ish. And if you look at the 25 cents per eligible per month, that comes out to $3 per eligible participant per year. And eligible participants are basically any adult member enrolled in a medical plan age 18 and over, of which there are just over 100,000 of those. So when we look at the global pricing model, we're looking at coming in somewhere in the sort of $300,000 to $320,000 range for the year.
So can I So $84,213 divided by 2,227 is 37, not 67. So where's the difference?
Yes, I can take that. And Margaret, please jump in. But the pricing model that we have right now is it's per enrolled participant in the online program. So it's the online program only. So that's the Kaiser Moda Providence line. And what we have been doing to engage the population post-pandemic has gone far beyond the platform. And that is by design, and we've been trying to do that. But have it be, inclusive of webinars and getting people enrolled in challenges. And all of those are not currently within the pricing model that we have contracted today. And that's what we are taking a look at, and we're saying that we want to change the definition of what is engaged per the contract to include the expanded scope of the services that we are going to be offering.
So right now, today, the current contract is $37 per person.
It is 60.
It's 67 per enrollment.
67.
So why is the total here $84,000? Because that's not like 2,227 times 67 or whatever it is not 84,000. So like, where's that? Like, this isn't the actual total.
So what you would do here is you would, from a true pricing perspective, you would remove this webinar because those are services, honestly, that we're offering right now that we are not being paid for. So you'd have to remove the 1,260 and the 4,700. The per participant is reflecting only what's in the Kaiser Moda and Providence line.
Okay. Okay, that helps. Thank you. So the primary product at this point is a web app with webinars included in newsletters at this point. Is that right?
The main product that you have is called the My Stay Well. It's the platform itself. So within the web contract, it's just the web app. Yeah.
Okay. So like I'm looking, like the average other web app, like My Plate or Stay Strong or those sorts of things are. I was kind of looking at this the other day, and this is like $45 or so for a year. Similar stuff, like nutrition tracking, sleep habits. They have like videos, and so like can you help me understand like what's additional that those kind of web apps that also exist offer?
Yeah, so I would say how we are different than just a web app is our services go beyond a platform only. So first of all, within the platform, you will have the ability to customize the platform, meaning that we can put in and create essentially a well-being hub for the Pebb participants, so we can integrate some of the other vendors that you have for easy navigation and an easy way to find, for example, the EAP program. So you're essentially also going to drive engagement in some of the other programs that you have. In addition, we are providing a full-time dedicated program coordinator. So think of this as a full-time staff person that their entire role is to drive the culture of well-being for the Pebb participants. And we've listed here a few different ways that this program coordinator could do that. But essentially, we are providing a full-time person to help drive engagement in the platform itself, but also provide some culture building activities through wellness champions that are sitting at the location. So think of, maybe there's a person named Sally in one of the departments, and they are very passionate about health and well-being, and they decide to offer a stretching break. Our team can help coordinate and work with those champion networks to help bring the well-being to the work site level without very much effort. So we provide them with turnkey tools and resources and toolkits to help them do that. In addition to that, we will also be providing 100 hours of custom communication support. So working with our team to provide, exactly what Pebb employees will need in order to engage in the program. So custom messaging, custom tactics to reach participants to help them, continue to engage in the program. I would say overall, what we're looking to do and what we know works is that we want to create a full, comprehensive well-being program that goes far beyond, just simply asking people to sign up for the app and have the app do all of the work essentially. We know that we have to have that comprehensive program design. And when we do that, we see greater behavior change over time.
And this is Brian Olson. This is just a reminder too that your advisory committee, PMAC, is going to be getting ready to make a recommendation to you guys. I'm pretty certain at some point this year about what it thinks the future health engagement model program should look like. And this will include, one of the features will be a central wellness platform. So I just want to let the board know that, based on the kind of work you're having PMAC doing, that there is going to be a recommendation coming down to you on this topic, and that the recommendation will be based on a review of evidence that we've done with Mercer and a number of presentations. So just to let you know that that is going to be coming down the road soon. So in terms of future plans, we just may want to take that into consideration.
Yeah, that's helpful. Thank you, Brian.
Yeah, I wanted to chime in on that too. I find that really helpful in knowing the coordination with Teresa Cross's work too, with the overall wellness throughout the agencies. So look forward to hearing that.
Yeah, and so Brian, just to be sort of specific there, Teresa has Teresa been seen this presentation, and have we engaged Teresa on this topic in particular, this presentation?
No, we have not engaged in this specific presentation in front of you guys right now, which is why I'm just letting you guys know that you'll see something similar. It won't be vendor specific, but you'll see something similar from PMAC, and part of that will be based on all the evidence that we've reviewed with Mercer and the other committees. And so again, if this is something you move forward, there is going to be some additional recommendations made to you guys at some point in the future that may conflict with this approach at some point in the future.
Yeah. Okay.
And Sean, this is Margaret, just to chime in. Teresa is part of our recurring regular program planning meetings with Stay Well. And so she's engaged in the current work that's going on in terms of the platform and how members are engaging with it, and the various webinars and challenges that are taking place. So she's absolutely part of those ongoing meetings we have.
Thank you, Margaret. So another, just actually, this is kind of my last question, I think. This slide right here, and this potential change in funding structure. Are there incentives or disincentives, or what is the incentive for WebMD, I guess now, to increase enrollment, right? In other words, is it financially structured in there that increased enrollment is, just looking at this, it looks like there's no financial incentive one way or the other. Is that true?
You mean and you're talking financial incentive for the participant or for us as a vendor?
For you as a vendor.
Yeah, for us as a vendor.
Your costs, your payments don't go up or down depending on enrollment, in other words.
Correct. The way we have this structured today and how we, how we have it today is that it would be a per flat fee, the per participant. The one thing that we are very comfortable doing is also putting performance guarantees in place. So once we would get into contracting, if there's a certain either percentage or participation that we want to make sure that we're aiming for, and we want to have some of the financials at risk for that. We're completely comfortable doing that because at the end of the day, our goal is to make sure that the program obviously is successful. We're engaging as many people as possible and truly changing the behavior of your population. We thrive on having long-term partnerships, and the only way that you can do that is if you build a program that really will work long-term. So we are happy to put fees at risk to make sure that we're hitting our mutual goals.
And this is Brian. Quick follow-up question. Have you guys had any of these initial conversations with our contracted carriers yet? And I ask because just for the board, just as a reminder to the board, we look to our carriers to manage that contractual relationship. And so it would just be good to know whether those conversations have taken place or whether you anticipate any, I guess, concerns or challenges in working through these issues with the carriers?
We have not engaged with the carriers yet. We did want to start with all of you to make sure that you were on board with the approach as well. We do not anticipate any concerns working with the carriers. Actually, WebMD works with actually a few of the carriers directed with other relationships. And the model that we will be proposing is very standard within the industry. So we don't feel like we will have any concerns from a contractual perspective with the carriers with this change. I actually think that it will be more streamlined compared to what they've seen with other clients and other vendors.
Okay, thank you.
Thanks for asking that, Brian. So just one last follow-up, and this isn't a question for this moment, but in the future, it might be useful to have a few examples of other arrangements where that has successfully worked. The connections with health, various other carriers and plans in the industry where those relationships and arrangements are already done, so that we can get an idea of some existing success.
Yeah, absolutely. We would be happy to provide case studies. I think just from our perspective, I can share with you, we do work with quite a few states as well. So we work with state of Wisconsin, the Commonwealth of Kentucky. We work with state of South Dakota, all with thriving programs. So always happy to share what they're doing well, and then also from a carrier perspective. I would say our relationship with a carrier is more of a reseller model. So this is a bit unique for us that we work with the carriers for the employer program, but we're also happy to share some of the relationships that we have with the carriers as well.
Okay, thank you.
Yep.
Okay, so we're way over. So was that your last slide, or is there some?
Yeah.
Okay.
Nope. Yep.
Okay. So thank you so much, Maureen and Melissa, for presenting to us, and great interaction, great dialogue. I try not to ever interrupt when it feels like we've got the flow going there with good conversation. But now I have to manage an agenda. So what do you all want me to do with the agenda?
So Kimberly, we have a decision page. Go ahead, Margaret.
Oh yeah, so Kimberly, this is Margaret chiming in. In the last page of the PDF, we do have a staff recommendation or board action requested. And so I'll pull that up. It's the last page of your packet, and it's very, very brief. And so this is just to note the migration to the new WebMD 1 platform and the global pricing structure, transition to that pricing structure is essentially required criteria for us to continue the Healthy Team, Healthy You program in 2022. With the acquisition of the program by WebMD and the enhancements they're making on that platform and approach to it, if Pebb wishes to continue Healthy Team, Healthy You in 2022, we need to make that transition. So the staff recommendation is provided, as I said, in the last page of your packet. We are recommending that we proceed with continuing the program in 2022. and migrating to that WebMD1 platform, along with the transition to the global pricing structure. I think, as was mentioned during the discussion, should the board decide to proceed in this direction, we can certainly pursue performance guarantees and those sorts of requirements in the contracting process. There has been a decline of enrollment in 2020, as was noted, but we're seeing increasing interest in the program and a lot of webinars and content happening this year that seem to have employees really becoming engaged. So our rationale is we'd like to continue to work with the program vendor on strategies to support member engagement and wellness, and have this program still available in 2022. I will note, in terms of timing, that we do need a board decision in order to plan for next plan year. And I believe the decision timeline, we have a little bit of room. I think kind of May is when we were aiming to sort of have a final decision. We are asking for board action today. And if there is additional information that you need to make a decision, we can plan to come back with that at the April meeting.
Okay. Crickets.
Yeah, Sean,
so
I was
this
going
is,
to actually ask if you wanted to, because you were the one that kind of had dove in, so I didn't know if you wanted to wait or where are you at on that. I just want to make sure you were heard.
Thank you. Thanks. So I feel like at this moment we for this next year, it's not like we have like an alternative plan worked out with Teresa Cross, and it's like, oh, this is the model and this is the vendor and this is the thing, and so we're ready to just like pull the trigger on that, so to speak. And so therefore I don't really feel comfortable like yanking the carpet underneath our members of just like, and you don't have anything right now, So, but as you can tell, like I want to see how this fits with our plans. I want to see how it fits with the presentation. Our PMAC committee is going to come with, they're going to have a set of recommendations, and we're going to need to look at our current offerings and see how it matches our expectations. That being said, for the decision today and going forward, I think it's, from my point of view, I'll make this motion that that we accept the staff recommendations on this proposal. I would like it as part of my motion that my expectation is that there will be performance guarantees in the contract related to this. That being said, the staff recommendation, I move that we accept.
Thank you, Sean.
This is Kate. I'll second.
Thank you, Kate. Do we have questions or comments?
I just had a question. Is this for 3 years? Because the slide showed a 3-year time frame, and it sounded like we were going to be getting recommendations from PMAC and Teresa. I mean, from in the fall maybe, or in the next few months. So should we be looking at this for 1 year rather than 3 years? That's my question.
Well, Siobhan, this is Brian. So legally, I'm not sure there's anything we can do to actually solidify this for 3 years because they're tied to our medical contract. So I think it's okay to endorse a 3-year approach, knowing that this will be kind of a renewal item as well, that the board will want to tackle in the next couple of renewals.
Okay, that's really helpful. Thanks.
I mean, I assume that the contract will be written in such a way that if situation changes, like we can dissolve the contract or do something different.
Well, yeah. So our contract is directly with the carriers, and we have all the necessary provisions again, and that's why that makes some of our wellness conversations just a little more complicated, because we don't always have that direct contract.
Got it.
Yeah.
Great comments and questions. Okay, so let's go ahead and vote. We have a motion to accept the staff's recommendations and to also make sure that a part of this includes some performance guarantees. And let's see here. So first up would, well, Kate, you did a second. Kim Harmon?
Yes, in support.
Thank you. Sean, you did the first. Mark Perlman?
Yes.
Thank you, sir. Siobhan Martin?
Yes.
Thank you. Jeremy Vandehey? We lost Jeremy. All right. Looks like the motion, any opposed? Okay. Looks like the motion carried. And now, sorry, I'm so sorry, Margaret. I didn't see that there was an action item. I don't have anything in red here cueing me to make sure I got a vote in there. So now we've got some issues. We're at 12:35 and I do have one public comment. So I need to make sure that we don't get cut off before the public comment. So we have Margaret and then Sean. So what are we going to do there?
I think we can just move to public comment.
Okay. Okay. So we received public comment, and if you, this was a later entry, so I'm not exactly sure if it was in your packets or not, but it's from Gregory Santiago. And this comment reads as follows. With the passage of the American Rescue Plan Act of 2021, Congress has increased the 2021 contribution limits to dependent care flex spending accounts from $5,000 to $10,500 for married couples and from $2,500 to $5,250 for single filers. I currently participate in ASI Flex Dependent Care, FSA, offered by Pebb. Once the American Rescue Plan was enacted into law, I contacted Pebb about increasing dependent care, FSA, contribution to match the new limits. I was told that Pebb was not participating in any future changes to FSAs at this time and that I could not increase my contribution to match the new 2021 limits. I find Pebb's refusal to allow its members to increase their dependent care FSA contributions disheartening. Oregon has been cited as one of the least affordable states for childcare, according to the statistics compiled by Child Care Awareness of America. Of the 2019 average price of infant care in Oregon is $13,518. The dependent care flex spending account is a valuable tool used by Pebb members to help offset the high cost of child care in Oregon by being able to use pre-taxed income to pay for child care. Increasing the 2021 dependent care flex FSA contribution limits to the new limit amount set by Congress would greatly assist the Pebb members in affording child care at minimal cost to Pebb. I see no reason for Pebb to not allow its members to increase their 2021 dependent care FSA contributions. President Biden and the Congress have recognized the need for affordable care by increasing the dependent care FSA contribution limits, and I strongly urge Pebb to do so as well. Sincerely, Gregory Santiago. And I did not note, I apologize, if Mr. Santiago joined us.
I don't believe so, Kimberly, but we'll definitely look into this. Like you said, we just got this last night and we'll have a report back to the board.
That's what I figured. And I was concerned that it didn't get in packets, so I did read it. So it is on the record. All right. Any other questions or comments for our March 2021 meeting? Okay, well, I'm going to call it adjourned and have a safe, wonderful St. Patrick's Day. Participate in social distancing and wear your masks and wash your hands, get your shots, all those fun things that I can say and maybe get away with. I don't know. Anyway, thank you all so much and take care, and we will see you again. Bye.
Thank you so much.
Meeting's adjourned.
Thanks. Bye-bye.